Добрый день, уважаемые участники нашей секции. Секция называется «Агротехнологии», и с нашей точки зрения это одна из ведущих секций форума, потому что форум, который проходит под эгидой Росатома, он объединяет не только вот эти новейшие технологии, которые включают в себя индустрию Росатома, но, как мы все понимаем, что без продовольственной безопасности и еды никакие новые технологии эффективными быть не могут. Поэтому в рамках этого форума мы сегодня с вами обсудим те новшества, которые есть в области аграрных технологий, те очень интересные наработки, которые могут быть имплементированы в странах с жарким климатом, то, что может быть сделано в совместной коллаборации между нашими учеными и учеными африканского континента. Секция будет вестись на двух языках, русском и английском. Вы можете
model was used. And using data from the histogram, dose volume histogram, the equivalent dose in 2 gray and biological effective dose were calculated. These are the results obtained from the calculations for the left breast. And from the table, it can be inferred that intraoperative radiotherapy in combination with 3D conformal radiotherapy delivered the least dose to the heart. This is very important for the left breast cancer treatment because the heart is more located towards the left side breast than to the right side breast. So therefore, it's very important to consider that when creating treatment plans for the left breast. In addition, the dose delivered in both simultaneous integrated boost and sequential boost were not significantly different. These are the results obtained for the right breast. Here again, the dose delivered by intraoperative radiotherapy in combination with 3D conformal radiotherapy delivered the least dose to the heart, to both heart and lungs. However, the dose delivered in sequential boost and simultaneous integrated boost were statistically significant. So based on the results obtained, some recommendations were made, and these are intraoperative radiotherapy followed by 3D conformal radiotherapy should be adopted in treatment plans, especially for the left breast cancer treatment. And also institutions that do not use 3D conformal radiotherapy can use intraoperative radiotherapy followed by 2D conventional radiotherapy instead of using just the 2D conventional radiotherapy. So in conclusion, the research investigated the optimization of dose to critical organs in breast cancer radiotherapy. All objective sets were met, and their developed recommendations could be applied in radiotherapy treatment of breast cancer. Thank you for your attention.
Thank you very much, Faustina, for your talk. You had actually over 3 minutes left. Maybe you would like to add something to your talk or greet somebody? If not, okay. Are there some questions to Faustina and her talk?
Okay, I would like to thank the organizers of this program and also for supporting us and everything. And also for TPU, I want to say thank you tonight.
Okay, it seems to me we don't have any questions to you. But I had a question as I was seeing your talk. It's not much my topic about breast cancer because it's not really related to me. But from your study, do you know, is there some differences of the statistical point of view that women can get breast cancer more on the left or on the right side?
Oh,
Do you know something about something like this? Because there are two of them. Just my question to you.
the only stats that about breast cancer is the rate at which women get and the rate at which men get. We know that women get it more often than men. So, like for instance, when you take 8 women, there is chance that one person will have breast cancer, whereas in men is about 1 in 1,000 men. So that's the statistics that I'm aware of.
Oh, thank you very much for your question, for your answer. So we don't have more questions for Faustina. Let's go to our third speaker in this round. Let's welcome Collins Awa. Collins is a master student of research in a training center for international nuclear education and career at the School of Nuclear Science and Engineering at the National Research Tufts Polytechnic University. The title of Collins' talk will be Combination Therapy, a strategy for optimization of nuclear medicine and therapy. Hello, Collins. You with us?
Yeah, please, can you hear me?
Hello, Collins. So please, start your talk. The stage is yours.
Yes, please, can you hear me?
Yeah, we wait for the presentation now. It should be loaded soon, I hope.
Hello, Dr. Swen. Please, can you hear me?
The technician should load your... Yes, here's your talk. Please, Collins, stage is yours.
Please, can you hear me?
What do you mean?
Can you hear me?
Что не так все?
Hello, please, can you hear me?
Collins, do you hear us?
Yes, I can hear you. Please, can you hear me?
Collins, please give us a signal that you are still online.
I can hear you, but
So he's probably having some technical troubles.
please, can you hear me?
Now, yes.
Yes.
Do you hear us?
Thank you.
Collins, do you hear us?
Yes,
Do
I can hear
just
you.
personal me? Is it okay?
Yes, and I hope you can hear me too. I hope you can hear me. Please, can you hear me? Hello.
Collins, we can hear you.
All right, thank you. So I'll be presenting on combination therapy as a strategy for optimization of nuclear medicine therapy. And I'll take this from
Надежда, вы нас слышите?
Да. Слышим, хорошо слышим.
So I'll build this from
Very nice, very good.
Miss Faustina's
Very good,
presentation,
thank you.
where she made reference to some sort of combinations with regards to breast cancer treatment. So first of all, nuclear medicine therapy, as most of us may know, is a form of treatment of cancers and other medical conditions, whereby we use radiation and radiopharmaceuticals in the treatment. And there are also other therapies involved in treatment of cancers which are not radiation or radiopharmaceutical based. So in this research or in this presentation, I've classified that as other therapies. So, and there is also a phenomenon where you can combine these two therapies. So for the purpose of this presentation, we'll call it combination therapy. And Garatin 2003 defined combination therapy as the use of two or more therapeutic agents with different mechanism of action to achieve a synergistic effect. So if you have two different therapeutic agents to achieve the same purpose, then that can be described as combination therapy. So, for example, in nuclear medicine, we have commonly we have two classification of nuclear medicine therapy, but there are also other forms of nuclear medicine therapy like systemic radiation therapy and stuff like that, but those are not so common. But traditionally we have brachytherapy and then external beam radiation therapy. And for example, in external beam radiation therapy, we have the 3D conformal radiotherapy, image modulated radiotherapy, image guided radiotherapy, stereostatic radiotherapy, and proton beam radiotherapy, and many other forms of external beam radiotherapy. What do we mean by that? What we mean is that it uses external beam radiation to treat the cancers. And we also have brachytherapy, which uses whereby the radiation seeds are placed inside the tissue or the cancer tissue, inside the body of the patient to deliver the radiation doses to the cancer. And then, for example, in systemic radiation therapy, we have a situation whereby the radiopharmaceutical is probably injected or ingested, that is drunk by the patient. And there are also other forms of nuclear medicine therapies like that. So that is that for nuclear medicine therapy. And some other forms of cancer treatment can be in the form of surgery, chemotherapy, immunotherapy, cryoablation, And we also have radio frequency ablation, bone marrow transplant, hormone therapy, targeted therapy, and many other forms of therapies. Now, when we combine any two of these different combinations, any one of these different combinations among each other, we have a situation in combination therapy. So why is it necessary for us to try a combination therapy as an optimization strategy for the treatment of cancers? First of all, the therapies on their own, that's nuclear medicine therapy, has its own limitations, and then the other therapies, as I've mentioned, also have their limitations. But there are situations where we can look at these two different therapies and then try to combine, make a combination out of them to limit or reduce the limitations. So in this diagram, you can see that nuclear medicine is delivering some, the potency of nuclear medicine has been reduced by the barrier of limitations. What's happening? Okay, sorry. So the potency of nuclear medicine in this situation. Sorry, I think there's an issue with a technical issue. Right. So there is the limitations of nuclear medicine, for example, is taken care of by combination therapy. That is combining other therapies with nuclear medicine therapy. So the goal of this is a review research which we did, and we wanted to identify the different possible therapies that can be employed in combination therapies with regards to nuclear medicine therapies, and also to review the difference in treatment outcomes between a single therapy cancer treatment and combination therapy. That is the treatment outcome, the difference in the treatment outcome. So first of all, we searched the internet and on PubMed, Web of Science, Scopus, ResearchGate, and other sources to identify some keywords related to our topic of research. And then we removed the duplicates and non-English articles. And then we also screened the rest by the article, the rest of the articles by their title and then the abstract. And then after that, we looked at the overall content, particularly the methodology of how they achieved their results. And then eventually we were able to get 5 of papers that were connected to what we were trying to look for. And these are the 5 papers we have. And all of these are part of the review papers which we considered. So the results of the papers from the review we had, we saw that L. Fakiri et al. Tried to treat pancreatic cancer at the preclinical level, and then he used lutetium PSMA 617 with immunotherapeutic agent. And then the therapeutic efficacy of the nuclear medicine therapy in the pancreatic cancer cell was enhanced, unlike using just one of the modalities. In the same way, Hayada et al. Also attempted treatment of neuroendocrine tumors, and that is a clinical study. So he combined radiopharmaceutical with another chemotherapeutic agent called capecitabine, and there was a better overall response rate and a progression-free survival compared to the use of just one single therapy. And then Karam et al. Also made a combination of radioimmunotherapy with chemotherapy in the treatment of non-Hodgkin lymphoma, which was a clinical study. And in the outcome, there was a significant improvement of overall response rate and a progression-free survival compared to just one of the modalities alone. Again, Sahan et al. Did a clinical study on prostate cancer treatment. They combined targeted radionuclide therapy and immunotherapy. And this combination therapy enhanced the anti-tumor effect and increased the overall survival, unlike just one single therapy. And finally, Kriendos et al. Also did a clinical study by combining external beam radiation therapy and TRT, which was a clinical study. So there was an improvement in tumor control as compared to just one of the treatments with fewer side effects. So in conclusion, we want to say that if you consider using combination therapies as in combination of radiopharmaceutical with external beam radiation therapy or chemotherapy drugs or immunotherapy drugs or any other form of cancer treatment, the results are the outcome is much more better as compared to using just one single therapy. And the results of the study also suggest that combination therapy can enhance the therapeutic efficacy of nuclear medicine therapy. And for this reason, the long period of about 15 years of clinical studies and clinical trials of cancer drugs, discovery of cancer drugs, can have some space. We can have researchers can have enough time to concentrate on developing and discovering more research. More cancer drugs because combination therapy, at least for now, takes care of the limitations of the individual treatments. So thank you very much.
Dear Collins, thank you very much for your talk. Do we have some questions to Collins? Seems to me not. Collins, yeah, please.
Thank you very much for your talk. In which cases it is impossible to use combination therapy? What are limits for combination therapy?
Actually, the phenomenon of combination therapy in nuclear medicine is a new phenomenon which is still being investigated. So for now, we don't have the full picture or we don't have the full details to some of these things. But we will say that first of all, if you want to know the situations, you have to look at the contraindications of the patient. For example, if a patient has a pacemaker, you may not, it may not be convenient for you to use external beam radiation for such a patient. So in that way, you have to also look at other modalities which you use, and just like that. So I think for now, the main thing you have to look at in combination therapy is the contraindication of the patient. If we say contraindication of a patient, it means is the patient fit to undergo that treatment modality you are recommending, because the patient may have some special situations which may not make him permissible for that particular situation, and that is contraindication.
Thank you.
Do we have some more questions to Collins? Okay, it seems not. Collins, I have a question to you. Okay. Do you see any chance to combine in the combination therapy you presented here also drug delivery systems?
Wow, that's an interesting question because drug delivery systems generally is also a very new sphere of research. So we can try something, but for now, off my head, I don't really know which sort of drug delivery system we can combine with any nuclear medicine approach. Yes, but we can. That's the need for research. So of course.
Thank you very much for your answer. Do we have some more questions to Collins? There's also no questions in the chat to you. Thank you very much, Collins. Oh, there's a question. Please, Festo.
I'm asking Collins, is this combination therapy system being practiced in Ghana?
Well, Ghana as a country, with respect to nuclear medicine, Ghana is very new to nuclear medicine, or nuclear medicine is very new to Ghana. So, I mean, as a matter of fact, we have less than 10 centers of nuclear medicine centers, specialized nuclear medicine centers. So, with regards to combination therapies, I would only say that I would only speak to with regards to targeted radionuclides. If you, for targeted radionuclides, yes, it is done in Kolebu in Ghana. But for other sophisticated forms of combination therapies, it's quite difficult. I mean, it's quite rare to find it in Ghana. For example, targeted radionuclides with the use of lutetium-177 and some other agents to treat cancers is done in Ghana.
Okay, thank you very much for your questions, Festo. There comes to my mind some other combination therapy in this way. Is there not also important the combination with for the patients with psychology, for example, or with the nutrition during they have cancer? Is it also part of the combination therapy you presented to us, or should it be part of it?
Please come again.
Now, should you also take into account psychological aspects of the therapy or nutrition aspects in the combination therapy you presented?
Yes. Yes. It's for the research we did. We didn't have any evidence of that, but I believe that yes, it's possible, especially if you want to define those like nutrition, dietetics, exercise, and all of that. If you want to define that as a therapy, then of course it can be used as in this situation.
Thank you very much for your answer. Do we have some more questions? Okay, thank you very much, Collins. It was very interesting.
Thank you. You're welcome.
Let's switch to our third participant. We have now Atif Mohammed from Egypt. Atif, are you there?
Yes, hello, I'm there.
Hello, Atif.
Yes, do you hear
Atif
me?
is a PhD student of Research and Training Center for International Nuclear Education and Career at the School of Nuclear Science and Engineering at the Tomsk Polytechnic University. The topic of Atif's talk is today accelerators in medical applications. Atif, are you ready?
Yes,
Ben?
do you hear me?
Yes, I can hear you.
Okay, thank you.
So the stage is yours, Atif.
Thank you so much. So today how can I choose? Just how can I change the file?
Что? Что он делал?
Yes. Now you can see the screen, right? So now I will start. Accelerator in medical applications. In my talk, I will speak about several applications of accelerators in medicine. First, what is the accelerators? Accelerators are the devices used to accelerate accelerated charged particles using the electromagnetic fields. So the accelerators is used in three major aspects. First, for precise and targeted therapies, second for medical imaging, and third for radioisotope production. So we have two types of accelerators machines. Have two types generally: linear accelerators or circular accelerators. The circular accelerators are divided whether cyclotrons or synchrotrons. There is other kind of betatrons, but it's not mentioned in this presentation. So for linear accelerators set up just the particles is accelerated in linear trajectory and to limited energy to limited energy less than cyclotron or other kind of machines because of to produce very high energy particles with linear accelerators, you need very long accelerators. So it's not practical. It's only practical for leptons like electrons or muons or something like this. So here the advantages of linear accelerators is it can be used for targeting and insensitive treatment. It also provides high conformal treatment planning. It reduces side effects and improve treatment outcomes. There is some configurations of some medical linear accelerators. Here is one sample of Electa company, and this is for Varian company for linear accelerators with cone beam CT system and portal imaging device. This configuration configuration of linear accelerator is um, is very good for non-coplanar radiation, as this table can rotate can rotate, and this device can also rotate, so they can target the tumor with the most precise possible dose. About cyclotron machines is based on some perpendicular magnetic field to these, and then the particle is injected in this gap and has some circular path. During its circular path, every time it's passed through the gap, it gets accelerated by electromagnetic by alternating electromagnetic fields. Um, this acceleration is limited at the limit when the accelerated particles reach high relativistic speeds. At this rate, the acceleration process is not synchronized anymore, and the RF frequency of the accelerated electromagnetic fields are not the same as the revolution frequency of the accelerated particles. Therefore, we need either to change the frequency of the RF frequency in this gap by decreasing it with time to synchronize with the revolution frequency of the particle. This results in a new thing called synchrotron, or by increasing the magnetic field radially from the center to outside, and this results into different machine called isochronous cyclotron. The difference between synchrosynchrotron and isochronous isochronous cyclotron is the synchrosynchrotron has a lower beam current, which is sufficient for radiotherapy but not sufficient for radionuclides productions. Just, I think it's just repetition of my words. So here's some cyclotron used for radiation therapy from company IBA, and this other configuration, this other synchrotron from Varian company. Proton therapy is one application of cyclotrons in nuclear medicine, where the protons deposit energy directly at tumor site, minimizing the damage to the healthy tissue. Cyclotrons are primarily accelerators used for proton acceleration in for proton therapy. Because linear accelerators can provide high energy protons such as circular machines such as cyclotron. It has two advantages of better dose localization and reduced damage to the healthy tissues. For isotope production, there is this one example of IBA company. There is this is a list of radioisotopes produced by cyclotron machines. This is some list of elements. For example, technetium 99 used for imaging studies, bone scans, cardiac imaging. Iodine 131 used for throat cancer treatment. Lutetium 177 used for targeted radionuclide therapy, such as neuro neuroendocrine tumor. Other examples such as gallium or samarium. Also, accelerators used cyclotron used for produce short-lived positron emitting isotopes such as fluorine 18, which is used for PET scans. It's good for for cancer diagnostic and staging and treatment monitoring. Okay. The second type of circular machine, synchrotron. The synchrotron based on acceleration, not in spiral, but in some enclosed orbit, where whereas the particle is accelerated, the electron, the confined magnetic field is increased, and the frequency of the RF frequency increased to a limited value. This is the largest synchrotron on the Earth till now. It's the LHC from CERN. It's just used for high energy physics experiments. Synchrotron is used also for radiation therapy, but its usages it's limited. It's not used widely. It has some advantages like the ability of to change energy of accelerated beams and the changing time of accelerations, lower weight of the whole system, but it has some disadvantages as limited beam currents, difficulty in setting up and working. Okay. These are some examples of synchrotron machines. This is from Japan. This is from CERN, and this is from the Radiological Center in Obninsk, Russia. These are now we will just mention some radiotherapy techniques based on accelerators. One of them is intensity moduled radiation therapy, which uses computer controlled accelerator to deliver radiation with varying intensities across different parts of the treatment area. This allows for precise dose shaping, confirming of the radiation dose to the shape of the tumor, while minimizing the exposure to the surrounding healthy tissues. Second technique is radiotherapy is image guided radiation therapy. It utilizes real-time imaging, often in form of X-ray or CT scans, to monitor the position of tumor before and during treatment. This ensures accurate targeting of the radiation beam, even if the tumor moves during patient movement or breathing. Third technique is stereostatic radiosurgery. It's high precision technique that delivers a single large dose of radiation to a small target area within the brain or other parts of the body. Despite it's called surgical, it's not surgical. It's some kind of radiotherapy. It used to treat brain tumors and other localized lesions. The last type I will mention is interpretive radiation therapy. It involves delivering a single high dose of radiation directly to the tumor bed during surgery. Accelerators with mobile capability are used to deliver the radiation while sparing surrounding healthy tissues. Thank you for your attention.
Atif, thank you very much for your presentation. Do we have some questions for Atif?
Yes, I have one.
Please.
What type of the accelerator is more effective in cancer treatment?
Can you come again because I couldn't hear?
What type of accelerator is more effective in cancer treatment?
In terms of treatment,
In
Cancer treatment. Which accelerator is more effective for cancer treatment? Yeah, she's asking.
it doesn't depend mainly on the accelerator type, but it's in the type of the beam and the energy and the tumor itself. So there is no such like the absolute perfect accelerator, but it's like it depends on the type of the tumor. But generally, the linear accelerator machines, in my point of view, is until now is the best for treatment
Thank you.
because of our current knowledge of them.
Do we have some more questions?
Hello.
Hi.
Can I go ahead?
Sure.
Please.
Okay, mine is not a question, but a supplement. My friend mentioned among the radionuclides, mentioned the iodine 131. I wanted to add the iodine 125. It's normally used in prostate treatment. Thank you.
Thank you.
Okay, thank you very much. Do we have some more questions? Yeah, here's a question asked in the chat to you, Atif. Which type is preferable in case of radiation exposure to non-targeted areas?
I really don't have sufficient information to answer this question because generally for accelerators, it's so linear accelerators can be used with some kind of changing the head of the machine to produce some spherical kind of X-ray, which can cover several areas. But I don't have sufficient information to answer such a question.
Okay, do we have more questions? Okay, it seems not. Thank you very much, Atif.
Thank you so much.
So let's go to the next speaker. It's number 5. Let's welcome Anastasia Galitsina from Russia. Anastasia is a student of medical faculty of Obninsk Institute for Nuclear Power Engineering, National Research Nuclear University. Anastasia's topic today will be combined radiotherapy and hormone therapy in unfavorable intermediate risk prostate cancer. Anastasia, are you here? Can you hear us?
There is problem with the connecting. I can't. I don't understand why, but I can't connect my video. Something. Do you hear me?
I can hear you. Please speak a little bit
Yes.
louder. Yeah, now I can see you. Welcome.
Okay. So good afternoon. My name is Anastasia. I'm
Please,
representing
Anastasia,
Obninsk Institute
start.
for Nuclear Power Engineering. I'm representing Obninsk Institute for Nuclear Power Engineering and the Federal State Pituitary Institution Meets Radiology of the Ministry of Health of Russian Federation. So let me present you a work about combined radiotherapy and hormone therapy in favorable intermediate risk prostate cancer. So statistics shows us that in most countries all over the world, prostate cancer leads by incidence cases in own oncology diagnosis. In Russian Federation, for last 10 years, prostate cancer incidences went up for a third. Also, we need to say that last year statistics shows us a trend to decreasing age of diagnosing prostate cancer, and currently average age of patient is lower than 70 years. So there is population of workable and absolutely social active men. Prostate cancer is a very heterogeneous disease, which includes cancers of different aggressivenesses with a defined forecast for life and volume of the treatment. According to National Comparative Cancer Network of USA, we have 5 types of risk of prostate progression of prostate cancer, from very low to very high. Gradation occurs on the basis of certain criteria, such as PSA level before treatment, TNM stage, and level of differentiation of cancer. I want to pay attention that in intermediate risk group, we have 2 subgroups, favorable and unfavorable group. That is very important because cases of relapse and metastatic differs a lot. Also, we need to say that for unfavorable intermediate risk cancer, optimal volume of treatment isn't defined yet. Moreover, there is no unambiguous recommendations for necessity and amount of hormone therapy while using combination radiotherapy. Importance of question is also based on advanced hormone therapy. Lots of scientists don't recommend using hormone therapy routinely in routine practice, and find that her prescription needs to be made only after weighing all risks because of side effects. Discovering all possible side effects of androgen deprivation therapy, we need to say that the most common symptom is erectile dysfunction, which is happening with each 4th patient. Moreover, now is known that long treatment with androgen deprivation therapy raises risks of development cardiovascular diseases and endocrine diseases, leads to depression, which can get worse because of erectile dysfunction. For discovering relevances of this problem and results of clinical cases and researchers, we need to take a look at experiences of our colleagues. So we made a scientific research and discovered the role of the researchers, which includes more than 3,500 of patients with intermediate unfavorable prostate cancer, showed that combination with hormone therapy statistically significant rises biochemical failure-free survival. And as you know, dose escalation can be realized as a combination as external beam radiation therapy and brachytherapy. Some researchers doesn't show statistically significant rising of biochemical failure-free survival comparing to IBRT itself. Summarizing, in the present time, that's unknown. Do we need to use hormone treatment for intermediate unfavorable risk prostate cancer, and especially when using radiotherapy? In 2016, French scientific Boula showed results of analyzing of toxicity of hormone therapy and radiotherapy for intermediate unfavorable risk cancer and radiotherapy itself. On chart A, we can see evaluation of quality of life, and on chart D, changing of sexual activity, and 0 is in no activity. We clearly see differences between 2 groups. In group with using hormone treatment, quality of life and sexual activity scientifically lower than patients without it. According to clinical recommendations of Ministry of Health of Russian Federation, combination treatment with hormone therapy with luteinizing hormone releasing hormone analogous is the main treatment tactic for these patients. So we have a question: can we achieve such a high results of treatment by using combination treatment without using androgen deprivation therapy for a rising of quality of life of our patients? We've analyzed results of treatment of 74 patients who were treated from 2016 to 2020 in CIV Medical Radiology Research Center in Obninsk. All patients were divided into 2 groups. In third group, patients were treated with combination therapy without hormone therapy. In second group, with addition of androgen deprivation therapy. Average age of our patient was 66 years, and median time observation was over than 4.5 years. In both groups, patients were treated with external beam radiation therapy on prostate zone and vesicles in total focal dose from 42 to 46 gray plus brachytherapy once. And in second group, patients were also treated with androgen deprivation therapy with luteinizing hormone releasing hormone. In average time for treatment with androgen deprivation therapy was 7.5 months. So let me represent the results. First, I want to pay your attention on failure-free survival with a median time 4.5 years, failure of prostate cancer was diagnosed for 3 patients. 2 of them were in group without hormone therapy. Also, it's very important to pay your attention on overall survival. While the patients, 4 patients died. 3 of them were in group with hormone therapy. Besides, no deaths were connected with prostate cancer. Moreover, we took a look on predictors which can be connected with failure, and we found that break between treatment steps longer than 4 weeks was connected with failure. Also, in group with androgen deprivation therapy, Gleason score 7, except exactly 4 plus 3 scientifically effects on failure. All patients who were diagnosed with relapse were having 2 and more intermediate unfavorable risks factors, as the gradation, third gradation group by Gleason score, more than 50% positivity biopsy scores, and 2 or 3 factors of intermediate risk. Frequency of toxicity there is some problem with presentation. That's not my slide.
Это все. Ну как-то. Она же ее листает. Почему не трогала?
Thank you. Yes, that's correct. So frequency of toxicity from lower urine tract was lower than 60%, and frequency of toxicity from lower digestive tract was a little bit higher in group with androgen deprivation therapy. Also, as for me, one of the most important and interesting results is toxicity levels in erectile dysfunction. Our experience confirmed very high frequency of losing erectile function while treating with androgen deprivation therapy. Only 30% patients saved erectile function. Besides, in group without androgen deprivation therapy, almost 50% of patients saved erectile function after treatment. That shows really big differences between 2 types of treatment of prostate cancer. So, summarizing all our results, we can say that statistically significant differences between 2 groups in failure-free and overall survival wasn't differs, and the frequency of clinical significant late toxicity was low and comparable. But significant differences between 2 groups and 2 types of treatments we found out in erectile function. In group without androgen deprivation therapy, it was saved in each second patient. That's the most important criteria which need to be noticed while treatment is planning. So, while conclusion and summarizing our results, we need to say that in present time, using androgen deprivation therapy while treating patients with intermediate unfavorable risk prostate cancer doesn't show rising of effectiveness of treatment, but shows rising of toxicity. Question of admitting androgen deprivation therapy still need to be discovered. Thank you for your attention.
Anastasia, look, thank you very much for your talk. Do we have some questions to Anastasia? Some questions online, some questions offline. It seems to me not.
Yes.
Okay, here's a question, please.
what's the prevention for prostate cancer?
I don't understand clearly your words. Very bad connection.
How can we prevent prostate cancer?
I don't hear.
Excuse me, I also could not understand you.
Prevention of prostate cancer.
So what's the question? I don't understand. You can type it.
What is the prevention for prostate cancer?
Steven, maybe you can help me with the question. Or you also can't hear.
Prevention for breast cancer.
Prostate.
Пост.
Yes.
Even prophylactic. It doesn't exist. It's only for one type. So for cervical cancer in women, we have 100% way to prevent cancer. It's vaccination against human populations.
Your question about prevention of cancer?
Yes.
Prevention is not about my work. I was talking about treatment. Prevention isn't about also medicine. We can't prevent cancer. It's not such a type of diagnosis which can be prevented. You can live healthy life and if you can say so, have good genetics, but we can't prevent it in any way. Prostate cancer is such a disease which can happen to every man, and it can be prevented anyway. It's just about genetic factors and mutations in cells, so that's not about prevention. Absolutely, we can prevent it anyway.
Is the question answered in this way? Do we have some more questions? Okay, it seems to me not. Thank you very much, Anastasia.
You're welcome.
So let's go to the next speaker. Our next speaker is Festo Kiraga from Uganda. Festo is a PhD student of Research and Training Center for International Nuclear Education and Career at the School of Nuclear Science and Engineering at the Tomsk Polytechnic University. Festo's topic of the talk today is high lead particle energy deposition in biological tissues for radiological therapy. A mini review. Festo, can you hear us? Are you there?
Very clearly, yes.
Hello, Festo.
Please, if you're ready,
if you're ready, the stage is yours.
Thank you. My name is Festo Kiraga. Briefly, that's the outline that I'm following. I start with the three situations that reflect an atom, the proton, the electron, and the neutron. The neutron, which is the focus of my talk today, is neither positive nor negative. So it's whatever. Neutrons are uncharged. They can not be accelerated or deflected. They make no interactions with the electrons when they meet a target, and they interact with the nucleus only, either scattering off or being absorbed. So the neutron has a light mass, as you can see. In terms of penetration, it's the most penetrative compared to any other particle. We classify neutrons according to energy, we have the cold neutrons with just a fraction of energy of EV. Then thermoneutrons are also less than half an EV. Epithermoneutrons are between half an EV and 10 keV. keV is kilo electron volts. Then we have slow neutrons, but our target today is the fast neutron, which has energy between 1 to 20 mega electron volts. For starters, fast neutron therapy started by the discovery of the neutron by James Chadwick in 1932. But the actual treatment was pioneered by Robert Stone in 1938, and around 250 patients were treated within that time, between 1938 to 1942. It is the Second World War that brought disruptions in the progress of this treatment. The aim is to treat 10 to 15% of tumors that that do not successfully yield results using proton therapy. Examples of such tumors include the salivary gland tumors, prostate cancers, and so many brain cancers. They are generated by, fast neutrons are generated by cyclones, and now most recently by medical accelerators. We have one in Tomsk. Very briefly, neutrons interact with tissues as when they pass through an electron cloud. They are always looking for a hydrogen atom for interaction, whereby alpha particles and other protons are released. When these particles are released, the protons, they create dense ionization chains along their path. And those ionization chains will be created in water and other macromolecules containing a high value of hydrogen, like lipids and lipoproteins found in the brain and the fat and the bodily fat. In the process, large quantities of energy is deposited, which is gamma. Gamma is kinetic energy released in matter. That process is called LET, which is called linear energy transfer. It can be low linear energy transfer or high linear energy transfer, and that's where the acronym high LET comes from. And that energy is deposited within, we have about 20 to 100 keV deposited per micrometer. My time is running fast. The deposited energy breaks the double-strand breaks of the cancer cells, hence curing cancer. Hence higher relative biological effectiveness. Briefly, in this slide, I tried to demonstrate linear energy transfer within a target volume, this circle here. If you use cobalt-60 gamma rays, very little is deposited there. If you use 250 kVp X-rays, you see the distribution in the purple. And then in the green, you see alpha particles depositing energy. So alpha particles in this sense have a higher linear energy transfer within the target volume. Then here, I'll talk about the Bragg. Let me concentrate on this slide here. Fast neutrons do not have a peak. The Bragg peak. Bragg peak is this plot, this curve that you're seeing here. The green one indicates a photon beam. you have a higher energy deposition at the entrance, closer to the surface. This is the horizontal axis here represents the depth within the tissue. Now, protons, which are released by when neutrons hit a target, they deposit their energy far deep within the tissue. You see the red curve here, more than 20 centimeters within the depth. So every deep lying tumor can be easily reached. Then we talk about RBE, which is relative biological effectiveness. Fast neutrons have a higher rate than photons. That one we have talked about it. The more double-strand breaks or DSBs, the quicker it is to reach the goal, which is the cure of cancer. Thus, fast neutrons have a high relative biological effectiveness compared to photons. How can we compute RBE, or relative biological effectiveness? We divide the reference dose over a high-rate dose. The reference dose can be 250 kVp X-rays or cobalt-60 gamma rays. So that's how we compute it. This figure reaches a maximum at approximately 100 kV per micrometer. I demonstrated that in this picture here. You see in this purple curve here, around 100 kV. That's what you have the maximum relative biological effectiveness is achieved at this level. So that's where the protons deposit the highest possible energy. In summary, fast neutrons are highly penetrative. They interact with only with the nuclei of absorbing medium. They are indirectly ionizing, and on the interaction with the nuclei, they put in motion recoil protons and alpha particles. Alpha particles, recoil protons, also deposit energy. Then that linear energy transfer is the one that goes to the DNA, hence the curing of cancer. Those are my references. I am from Uganda. Thank you.
Okay, Festo, thank you very much for your talk. You're really much in time. Well, do we have some questions to Festo in this talk? Please don't be shy. Let's ask some questions to Festo. So, Festo, luckily for you, no question, it seems to me.
Thank you.
So, thank you very much.
Welcome.
Let's go on with our last speaker for the first session. Let's welcome Aliyu Musa from Nigeria. Aliyu Musa is a master's student of Research and Training Center for International Nuclear Education and Career at the School of Nuclear Science and Engineering at the National Research Tomsk Polytechnic University. The topic of his talk today will be cyclotron production of 64 kappa by alpha irradiation of nickel. Musa, can you hear us? Can you hear me?
Yes, can you
Are
hear
you
me?
here?
Yeah, I can hear you. Can you hear me?
Okay, Musa, are you ready?
Yes, I'm ready.
Okay,
Hope you
Musa,
can see me. Okay.
then please,
Um,
go
uh,
on, your stage is yours.
okay. My name is Musa Ali Musa, and the topic of my presentation is cyclotron production of copper 64 by alpha particles irradiation of natural nickel. Though my presentation is going to be like a progress report of the research I am presently doing. And this is my presentation outline.
Full screen, please. Full screen.
Yeah, it's in full screen, I think.
It's not full screen. Can I show you presentation?
Okay.
Okay, now we have full screen. Please go on.
Okay. Next, this is my presentation outline, and this is the introduction. Currently, as you know, nuclear medicine is increasingly being used for the treatment of cancers for both diagnostic and therapeutic purposes. And in general, diagnostic and therapeutic are separate processes and use different radioisotopes. However, there are several radioisotope pairs that can be used for diagnostic and also therapeutic purposes, which are called radiotheranostics. And copper 64 happens to be one of these very few radioisotopes that are theranostics in the medical application, such as which are used in the imaging and the cancer treatment. And one of the most promising methods for producing copper 64 is by using a cyclotron. And the production of copper 64 in a cyclotron typically involves using a target material, such as natural nickel, and bombarding it with a high energy alpha particles. And this results in the production of copper 64 through the alpha nickel production route. Once the copper 64 has been produced, it must be purified to remove any impurities and to ensure that it is suitable for medical use. And the production proper copper naturally, technology for producing radionuclide for patient care studies is well developed, both at reactors and accelerators. However, for some newer emerging medical applications, there are increasingly demands for two types of novel radionuclides, which are the longer-lived phosphoron emitters and the low-energy, highly ionizing radiation emitting radionuclides, which are used for radiotherapy of deep-lying tissues. And the development of a novel radionuclide demand interdisciplinary studies involving nuclear data measurements, target construction for high current irradiation, and devising chemical separation schemes to obtain high purity products, and finally elaborating quality assurance tests for human use. Over the last 3 decades, many postgraduate emitters have been developed, such as copper 64, deuterium 86, and the iodine 124. And many of these PET radionuclides are produced at a cyclotron via a low energy, either proton-neutron reaction or alpha or deuterium reaction routes on a highly enriched target isotopes. And this is a scheme for the overall radioisotope production, where the target is being irradiated. After you prepare the target is being irradiated. After the irradiation, you have the irradiation mixture, where you have the combination of the radioisotope you produce with some contaminants. After that, the irradiation mixture will undergo radioisotope separations, where it will be dissolved, and the solution will be extracted / separated, and so that you obtain your pure radioisotopes and the radioactive impurities. So that you separate your pure radioisotope from the radioactive impurities. And at the end, you have your pure radioisotopes. And these are some of the stages in the production of radionuclides. These are some of the stages. I'm currently in the research I'm doing presently, or in the studies I'm doing presently. I am at this stage of target preparation, which I am going to discuss how I did my nuclear production selection routes. And the method I use in selecting the production routes, the nuclear selection routes I am going to use for the production of the copper 64 is I use Tally's some data I got from Tally's. to TENDEL 2017, which is TENDEL stands for Thales Evaluated Nuclear Data Library. And after getting the data from TENDEL 2017 for this particular production roads, then use the data to, can you hear me? I use the data to analyze. I analyze the data and I use it to compute and generate a plot of this particular production road. That's the plot of the cross section for this particular production road. And in the next slide, we are going to see the plot. This is the plot of this is the plot I got using the data obtained from the TENDEL 2017. And as you can see, according to the data I got, the cross section for this alpha nickel production road is highest at alpha particles energy of 30 mega electron volt. And at this energy, as you can see, this is 30 and this is the highest at this 30 mega electron volt. And at this energy, the cross section is approximately 425.3 millibands. Sorry, as the energy increases or decreases from the optimal value, which is this, the cross section decreases rapidly. So as you decrease the energy, the cross section also decreases. And the moment the energy exceeds this optimal value, that's the 30 mega electron volt, it begins to decrease rapidly. And from this plot now you can see we have at least about 425.3 millibands. Though the energy I'm going to use, the energy of TPU cyclotron is not up to 30 mega electron volt. The deuterium energy in TPU cyclotron is not up to 30 mega electron volt. It's around 28 mega electron volt. So if I'm going to produce copper 64 using this, I'm going to have a cross section of about 40 mega, sorry, a cross section of about 400 millibands, which is a little bit okay. And I am expecting to have a very, at least a good yield at the end of my production. And I compared the production road I'm going to use with other production roads. And though these production roads are being used, and if you look at some of the energies in which you have a very good cross sections, the energies are far. Like in the one with red, you see the energy for deuterium is about 25. And the energy for TPU cyclotron deuterium is not up to that. It's not up to that mega electron volt. Likewise, in the proton zinc production roads, you can see the energy of the proton there is more than 25, which the TPU cyclotron proton energy is not up to that amount. And likewise, in the other plots, you can see the deuterium nickel reaction, and the energy this energy is around 15, and you have, but this production road is commonly used, and I want to introduce a novel production road to see if I will get a new yield, which in the I want to introduce, I want to use a novel production road. That's why I did not go for this. And with this production road, you can see that considering the energy of particles in the cyclotron I'm going to use is not up to this. So that's why I decided to go for the other production roads. That's the alpha nickel production road. And using this cross-section data, it is possible to optimize the production of copper 64 in a cyclotron by adjusting the energy of the incident particles. And the production of copper 64 using a cyclotron can result in the formation of various impurities, and which can affect the purity and quality of the final product. And some of these puritic impurities in copper 64 produced through an alpha nickel reaction includes copper 61, copper 62, copper 63, zinc 64, and cobalt 56. And the formation of these impurities is due to the presence of other isotopes in the target material, as well as the possibility of secondary reactions occurring during the production process. And in conclusion, in this present study, I present a new production road using the alpha-nickel reaction, which has not been studied so far, and has the potential to offer several benefits such as improved yields, higher purities, and simplified production processes based on the cross-section data obtained from TEDL 2017. And the use of copper-64 radiopharmaceuticals in medical imaging and therapy has shown promising results, and development of new production methods will enable further advancements in the field. Thank you for your attention.
Thank you very much for your talk, Musa. Do we have some questions to him? So do we have some questions to Musa? Okay, it seems not. Musa, can I ask you one question? Can you explain me a little bit more, because I had a problem to understand from your talk, for which I need 64 copper in nuclear medicine? Which applications we can have it?
Oh, it's used for theranostic purposes. That it can be used for both imaging and treatment, cancer treatment.
So for imaging, you say, yeah?
Yeah, for imaging, theranostic means it can be used for both treatment and imaging. That's both diagnostic and treatment purposes. So you can use copper-64 for that. That's why it's called a radiotheranostic.
I see. And is it also clear that you don't have oxidized versions of copper, what you can use there? Because copper-1 especially is very cell toxic. You don't produce it, yeah?
Yeah, I'm presently on the process of conducting the research.
Okay. So do we have some more questions to Musa? You're lucky. It seems not. So, Musa, thank you very much for your talk. So, that was our last participant for our first session. Thank you very much for your attention. And now we go into a break, and we see for the second session at 12:30. So, enjoy your break. Thank you very much. Have a good time. See you later. Goodbye. Oh.
Now I'm back. I think you can hear me, right?
Excuse me? Who spoke there?
Yeah, I was talking. Yeah. Excuse me for my early departure before, because my boss called me because there were guests from Italy. That's why. But now I'm back. Yeah. Thank you very much.
Nice to meet you.
See you later. Nice to meet you.
It's Professor Hagas.
Yes.
Very good. We would be welcoming you at just about 10.
Yeah.
12:30. Yes, 12:30. Right.
Yes.
12:30 your time, local time, right?
Yes.
Now we are having a small break so that the speakers, participants could have some small rest.
Right.
Thank you very much.
Thank you very much.
I'm very happy that you are with us today.
Yes. But
finally, we
sometimes, when you are over engaged, that's the problem. When you become Duke of nothing, Yeah. Sorry. Anyway, I ask apologies for that.
Do not please take it too much seriously to the heart. You see, it's normal. It's every day our work and duty. Something happens. We understand everything. No troubles.
Okay. So see you soon. Then.
See you soon. Yeah, thank you.
Okay, thank you.
Надежда, у нас получается сейчас перерыв, да, и мы не отключаемся. Все верно? Все ушли.
Нет, не ушли. Я тут не надо отключаться, а то вдруг не подключитесь.
Да, вот я решила, что мы...
Лучше так повисим, ничего страшного.
Хорошо, я камеру выключу и звук, чтобы нас не слышно было.
Хорошо.
Спасибо,
тогда
Да, Надежда, я вам еще презентацию последнюю отправила.
Я видела, да, вот как раз сидела, смотрела все.
Да, не стала лезть туда, ну, в эту папку на всякий случай, чтобы не прерывать тут общение никакое.
Да,
мало
да,
ли
все
что.
правильно. Спасибо вам
Технически.
большое.
Ага, все, спасибочки большое вам.
Это еще кто-то будет, да, выступать?
А
вот
это вот у нас товарищ, который не подключился, он на работе был на дежурстве. Сейчас
Ага.
он приехал домой, выслал мне лекцию, и сейчас пробуется подключаться. Эдмунд Чума, он выступает под номером 5 сегодня во второй части.
Ага, сейчас я посмотрю, как раз я буду его иметь.
Это единственный спикер, который не подключался в тестовом режиме, потому что у него не было возможности в онкоцентре в своем подключиться.
Ну да, понятно, ага. Эдмон Чума, поняла, сейчас я посмотрю, если
Ага,
что,
пятый
чтобы я его
номер.
пустила, да.
Хорошо,
спасибо.
спасибо. Спасибо, Надежда.
Пока.
На смену придет у меня Александр, сменит в 12:30 он уже будет. Александр Питерский, другой наш сотрудник.
А что, ну, в принципе, все, это как бы вы...
Ну, все
это
равно...
вас просто пригнал, я так поняла, Станислав, но вы мне ничем не поможете, вы же не знаете, какая у них там проблема. И я не знаю, если бы я знала, что у них там на том конце...
Я понимаю, у Стаса получилось только сессию перегрузить, и все. Он говорит, как бы, сессия устарела. По-моему, конечно, нажал просто F5, перегрузил, человек вот, подключился в вебинар.
У него?
Да. Вот здесь вроде бы, как он это сделал.
Ну, может быть, хорошо, что
Не
вы
у
мне
него,
сказали.
конечно, потому что...
Просто я попросила человека зайти под другим именем.
Не параллельные процессы, а последовательные.
Надежда, здравствуйте. Вы уже в кабинете?
Да, здравствуйте. Ну, еще не все коллеги, я так понимаю, подошли. Вот.
Ага, ну мы просто даем знать, что мы на месте, все нормально. Все.
Может, пока откроем дверь?
Можно подставить стул, если что.
Я знаю, как
Probably yes. 10-12 minutes for talk, yes? And plus 5 minutes for the discussion. I think we will manage. And by the way, Sven, we...
Контакты докладчиков.
Ну, наверное, есть у модераторов, а что нужно?
Границы, телефон. Границы. Ну, было бы очень хорошо, по крайней мере.
А что вы хотите? Просто можно сейчас спросить, вот представитель здесь.
Телефон должен переговорить по поводу...
Надежда?
Да.
Смотрите, такое дело. У нашего товарища Эдмунда Джозефа из Танзании такая же проблема, вот как с этим другом.
Да. Вот попробуйте, чтобы, может быть, чтобы он обновил браузер.
Да, я напишу. Да. Хорошо.
Ctrl F5, скорее всего, надо нажать, может быть, поможет. Или точно так же переименоваться.
Да, Саня. Онлайн.
Онлайн.
Онлайн. Samuel online.
Они забили. Они с утра уже были, мы всех проверили. Просто они повторно зайти не могут. Их тормозит. Позволяют ждать.
So all online.
Almost everybody here.
So.
А вы можете оставить контакты свои? Спасибо. Что прислать? Вот я с ней на переписке. Вот вы можете ей написать. Хотите, вот, Анастасия, что вы хотите предложить?
Я хочу попросить ее РИА Новости.
Да.
Телефон.
Так, кто у нас сейчас на связи из участников? Дэвис is here, Котлека is here, Полина, Сэмюэл, Коллинз, Анастасия. Так, Дэвис. Джонатан. I don't see Jonathan here.
Ну, давайте я свой оставлю, да? Да понятно, но может быть не может. Да? Давайте, какой плюс?
Samuel is here.
Ага.
So, Polina is here. Joseph Tibopil is here. And Samuel is here. Now I want to find out about Mutambi. Is Mutambi here or not? I don't see him actually.
Она вот сейчас еще, наверное, она уже выступала, да?
Да.
Also don't see.
Надежда, тогда мы начнем, наверное, да, уже что?
Да,
Без
пожалуйста.
20 уже все хорошо. Свен?
Я только очень прошу Анастасию Голицыну посмотреть от меня личные сообщения.
Это вы мне сейчас говорите, да?
Нет, Анастасия Голицына.
Ага, хорошо. Sven, we are ready to start, to proceed.
Hello, everybody. Welcome back to our second session of nuclear medicine. I would like to say hello again to everybody and also hello to everybody who's new in our session. For them who is new, I would like to introduce myself again. My name is Dr. Sven. I'm a research scientist and associate professor at the Tomsk Polytechnic University. And I'm the moderator of this session, together with Dr. Hagos Tesar Medin from Ethiopia. So for the first talk in the second session, we have Dr. Polina Vichnakova. Are you here? Can you hear us?
Yes.
Hello and welcome, Dr. Polina.
Yes, we can hear you. We can hear you, yes.
So let me introduce you, please, first. Dr. Vichnakova is the head of a laboratory for regenerative medicine, FSBI, head of the Laboratory of Molecular Pathophysiology, associate professor of the Department for Histology, Cytology, Embryology at the Ruden University. And to talk to you, wants to speak about today is multimix studies of radiobiology effects in cancer treatment with proton and neutron radiation. Are you ready?
Yes.
Then please,
Okay.
the stage is yours.
Thank you for the nice presentation and thank you for the invitation to this forum. I'm happy to be here. And now I'm going to speak about multi-omics technologies in the view of radiobiological effects at curing cancer. Multi-omics technology is now a frontier area of biology because if you have one sample from the patient, you can understand at different layers, different information about this patient. For example, genome of the patient, metagenome, transcriptome, proteomics data, and metabolomics data. This integrative data could be uploaded on the website, and this integrative information from the site could be helpful in analyzing what happens really with the patient with certain nosology. As you know, during ionized irradiation, the main target of the beam is DNA of the cancer cells. And this beam could produce two types of break in the DNA, single-strand break and double-strand break, which is much more difficult to be repaired in the cancer cell. Ionized irradiation is different. And if we compare neutron irradiation, for example, to gamma irradiation, we could see that the speed of this irradiation is much lower, but the ionized potential of this neutron irradiation is much higher compared to the photon irradiation, gamma irradiation. So in radiobiology, it's often we could find that these types of ionized irradiation could be divided in two main types, low lead and high lead irradiation, which is depend on the linear energy transfer. So in our work, we are interested in the high lead irradiation, neutron and proton. As you can see, high lead irradiation makes very direct, very dense beam and influence on the cell directly compared to the low lead irradiation, which does it more diffuse. 2 years ago, we won the mega grant, which is concerning the personal strategy of the oncological diseases with help of neutron irradiation. And the head of this grant is Professor Andrei Dmitrievich Kaprin. One of the main goals of this grant is the search of molecular signatures which are activated during proton or neutron irradiation in 3 different model systems. The first system is cells, it's in vitro study. The second model is in vivo study using xenografts. And the third one is the irradiation of the patients. We analyze only one multi-omics technology, transcriptome, before and after this exposure to neutron or proton irradiation. Not everyone here may be faced with the data of RNA sequencing. That's why I added this slide. You could see volcano plots, and on this volcano plot, you could see that red points are the genes with significant down or up regulation meaning. And from the right side, it's up-regulated genes, and from the downside, it's down-regulated genes. So the first part of our study was to expose the cells to the neutron therapy. Our in vitro model is tumoroids from the cancer of the neck. We formed these tumoroids with help of uncoated plastic, and then we went to the Obninsk, where the neutron synchrotron machine is situated. In this giant water cube, you could see the focusing of the beam on 4 Eppendorfs with tumoroids. And all in all cells exposed to the dose of 10 grays during the neutron exposition. Another slide with the cells and the focusing of the neutron beam. So what we found, as you could see on the slide in the table, I added most up and down regulated genes after exposure compared before the exposure of the cells. And if we performed enrichment analysis, which could help us to analyze which gene is associated with certain signaling pathway, you could see that after the exposure of the cells of the tumoroids, the most activated pathways are protein folding in the endoplasmic reticulum, microRNA processing, translation modifications, protein refolding, and others. If we build the GenNet, which could help us to find the most the genes with the maximum count of ages, you could see that this gene is UBC, and I will tell you later about this gene. Second part of our study is the exposure of xenograft models to the neutron therapy. We implanted cancer cell to the under the skin of the mice. It was mice without tumors and nude mice, and then we also exposed them to the neutron therapy with such plexiglass disc for the focusing of the neutron beam. And what we found after the neutron irradiation compared to the situation before irradiation, you could also see the top genes with up and down regulated meaning. And enrichment analysis found out that the most activated signaling pathways was, it was a surprise for us, the regulation of viral transcription, viral life cycle, and also negative regulation of the apoptosis and cyclin-dependent protein activity. Again, if you could see on the slide, GenNet demonstrate us that the maximum gene with the top ages is again UBC, and another one is the gene of cyclin-dependent kinase inhibitor. Here it is. The third part of our study is the exposure to the proton therapy of the patients. It was performed again in the center in Obninsk with the summary dose of 10 grays. We found that after proton exposure in the patients, we found different up and down regulated genes compared to the situation before. We compared two types of biopsies after and before the exposure to the proton therapy. And what we can see that most signaling pathways activated after the proton therapy in the patients, it was the head and neck cancer, was again cytoskeletal protein, it was cell adhesion, it was enzymes in conversion, and protein scaffolding. GenNet revealed again that we found the same gene, cyclin-dependent kinase inhibitor 1, in the case of the patients after the protein exposure. So what is UBC? UBC is the gene which is encoded the protein polyubiquitin. Polyubiquitin, it is the marker of cell death and also the protein death. If the protein is marked by UBC, it means that it should be degraded. The gene of independent kinase inhibitor 1A is a gene which is responsible for the very powerful inactivation of cell cycle, and its expression is activated by the protein P53. So all in all, we could conclude that in 3 different models after the particle therapy, we see the
synergical general effects concerning the transcriptome data. And the main agents in this molecular signature is two proteins. It is UBC and cyclin-dependent kinase inhibitor. All in all, this work is a result of a lot of people from different organizations, and I want to thank everyone who included in this project. Thank you for your attention.
Thank you, Dr. Vichnokova, for your talk. Do we have some question to the speaker?
Yes, I have a question.
Please, Collins, go on.
My name is Collins. Please, during the research and when you were irradiating the mice, did you also consider the DNA of the normal cells of the mice?
The
Because
DNA?
I think you were...
The DNA of the mice?
No, I would rather say that did you consider the normal cells around the cancerous cell which you put in the mice?
In case of mice, we only analyze the biopsy of the cancer, but not the tissue around the cancer. And we analyze only transcriptome because it was a very tiny piece of biopsy. That's why we could not share it between analyses. I mean, DNA sequencing and RNA sequencing. That's why in priority, we want to know what's happened with gene expression, but not the genome.
Okay, so I would rather say that because it's a form of, because you are doing irradiation, I would suggest that you also consider the normal cells around the place where you put the cancer cells, because the irradiation can possibly also affect the DNA of the normal cells. So maybe it will be interesting to also look at it.
Yes, thank you. We perform such type of analysis in case of humans, in case of patients with head and neck cancer, but I didn't show this result here. But as you know, particle therapy, neutron and proton therapy is much more safe for the around tissue, for the tissue around the cancer biopsy. Compare, for example, to gamma irradiation. That's why.
Yeah, that's true.
Thank you for your question.
Okay.
Thank you for your question, Collins. We have also a question from Dr. Hagos Tesfa from Ethiopia. I'd like to know, will it be feasible to collaborate with you on such project?
Yes, of course. We are open for all collaborations. You could see my email on the last slide or see it in the record of the forum. So you could write me and I will answer you. Thank you.
Do we have more questions? I would like to have one question to you. You showed on slide 27, if I see correctly, that protein misfolding, protein aggregation, and which are cytotoxic. Is it in this way possible with radiation stimulation to introduce such a protein aggregation for the cell death, especially for cancer cells?
Yes, I agree with you. Maybe we could see in this data the kind of cell death from the unfolded protein response, which also could lead to the apoptosis. So that's why these signaling pathways could be associated finally with apoptosis in these cells.
Okay, thank you very much for your answer.
Thank you very much.
Do we have some more questions? Yeah, thank you very much for your talk. Let's go to our second speaker in this second round. I would like to introduce Joseph Taglego Upa from South Africa. He's a graduate from the School of Nuclear Science and Engineering, National Research Tom Polytechnic University. The topic of the talk will be today review of Monte Carlo tools for personal dose equation calculations to the operator in individual radiology. Joseph, can you hear us? Are you here? Hello, Joseph? Seems to me he's not here.
Hi.
Hello?
Oh, I'm here. I'm just trying to see how I will connect.
Hello, Joseph.
Thank you so much.
How are you?
I'm good. Thanks. And yourself?
Okay. Please, also to the other speakers, 10 minutes for the talk and around about 5 minutes for the questionnaire.
For the questions. Okay. Perfect.
Okay. So nice to have you here. Are you ready? Please. Then, Joseph, the stage is yours.
Okay. A window. There we go. Okay. Can you all see my presentation?
Yes, now we can see it.
Is it on full screen? Hello?
Yes, your talk is to seen and you can hear you. Please go on with your talk.
Oh no, I was asking if you could see my presentation and if it's in full screen.
Yes, it's in full screen. We can see it.
Okay, thank you so much. So, okay, good day, colleagues. My name is Katleho Sabopela, and I am a nuclear enthusiast from South Africa, and I represent an organization called the South African Young Nuclear Professional Society, which is basically the South African Young Generation Nuclear Organization. So I studied both nuclear engineering, that's in my country. Then I came to Russia, then studied nuclear medicine. And so, as Sir mentioned, I'm an alumni of Thomas Polytechnic University. So I thought I should pay homage to the institution. As you can see on my slide there's a logo of the university, because that's where I did this research under the supervision of Professor Konstantin Stanlovich. And yeah, it's an honor to be part of this initiative, the Russia-Africa Forum. And I'm hoping that we'll learn and expand our knowledge today. And yeah, I'm hoping that this research will do just that. Thank you so much. Okay. So just in a brief introduction into my research, as my topic was mentioned earlier, which is a review of Monte Carlo tools for calculating the personal dose to the operator. So this comes because of due to an increase in fluoroscopy guided intervention radiology procedures. So there's a need for us to use computational tools in order to estimate the dose to both the patient as well as the operator. But then in most cases, it's more the operator because they do these procedures on a constant basis. So skin injury, in most cases, which is what the patient will mostly be exposed to when will basically experience when exposed to radiation. If the dose basically exceeds what we call the peak skin dose, the peak skin dose, this could lead to severe injuries and then cause deficiencies such as arrhythmia and epilation. So it's important for us to practice proper radiation reduction techniques in these procedures in order to protect both the staff and the patients. So these models that I'll be talking about, computational models, Monte Carlo models, they consist of an anthropomorphic computational phantoms, which represent the human body, the anatomy, and in a form of a computer model. And radiation transport codes such as these basically are used to simulate that whole procedure. Okay. Next slide. So the aims and objectives of my study, basically what I did was to do a comparative analysis looking at these two Monte Carlo codes, which I'll mention later on in the presentation, and to calculate, in most cases, my focus was to, in this case, was to review the deep dose, which is the radiation received by the operator. But as part of my study, part of it as well, I also did calculated the dose received by the patient and estimated how much would the, using computational tools, how much would we get by estimating the pig skin dose as well. And I also compared some softwares there as well. But then the important thing for this one is to actually look at the Monte Carlo ones and then the dose and focus on the dose received primarily by the operator. So to meet the aims and objectives of my study, I needed to understand the experimental setup involved in calculating the personal dose equivalent, and also, I suppose, all the algorithms used. In this case, these are the Monte Carlo algorithms. So what I did was I used these tools, and then basically how I compared the tools is using the accuracy ratio and the deviation ratio after basically comparing the experimental results to the simulation results that I got using these tools. So the relevance of my study, so as I mentioned earlier, operators are constantly exposed to radiation during interventional procedures. So it's important for us to actually try to minimize that by using such tools in order to simulate the procedure before they can actually do it, so that we can actually be able to optimize the procedure on their behalf, and therefore we minimize the radiation dose that they can receive when performing the actual procedure. So in this case, so these Monte Carlo tools I'll be talking about have been developed under the Podium project, the personal online dosimetry using computational method project, which aims to solve these problems that I've just mentioned. And then the idea was for them to basically develop an online system, an accessible online system for everyone, for operators to use to actually be able to estimate the dose before an actual procedure. Okay, so here we are. The two tools that I've been speaking about. One is called Penelope, PenEasy, and the other one is called MCGPU. And then these are basically Monte Carlo base codes, as I've mentioned here. So in the computational framework, the radiation transport is basically split into two parts. So I'm just basically explaining how these codes basically work, right? They split the computational framework into two parts and separate the sequential simulation to account for both the dose to the patient and as well as the dose to the operator. So basically the first simulation will focus on the patient, taking into account the patient's anatomy, the position, as well as the C-arm X-ray source, the geometry, position, and again, importantly, the emitted primary radiation, which is coming from the focal point, which is from the patient. So during the procedure, the radiation first interacts with the patient in most cases, and then it bounces back and it interacts with the operator. So that's what the first part of the simulation will basically simulate. And then from the first simulation, a large space file is created, and it gives the energy direction of the secondary radiation scattered towards the operator in that case. So the second simulation, basically, which is important, is what will basically focus on the operator, and it takes into account the large phase spill created in the first simulation as well as the operator's anatomy, as I mentioned. And in order to maximize the information obtained from the secondary beam, which is the beam coming from the patient to the operator, the variance reduction technique is used. And then this is a form of a particle recycling model. So with the code, those can be obtained at a voxel level, where the phantom of both the operator and the patient are voxelized. And then at the same time, the phantom represents the operator and the patient, but then the phantom can be scaled to specific physical dimensions of the operator and the patients. So for that purpose, validation with experimental measurement, the personal dose equivalent can actually be calculated. And then that's at a depth of 10 millimeters, according to the ICRU. So yeah, basically that's that. And then as you can see on my screen there, that's basically mostly how the interface of both codes will look like. So the first code that came was actually Penelope, and then MCGP was actually developed from using Penelope. So the interface that you see on the screen will mostly be applicable to MCGPU. During my research, I just couldn't find the actual interface for the Penelope software tool. Okay, so here we come to the core of the computational tools and how they actually do the calculations. As you can see on the screen there. So this is basically the algorithm that both computational tools actually use to calculate the deep dose to the operator. So as you can see, the algorithm, it sums up the dose in a form. Okay, so you have the normalization factor, which is represented by n, and then it is calculated per history. And then you also have the tele phantom fluence point of energy. And then this is actually sectioned in bins, basically just represented by I. So it can be as many bins as possible. And then that's also calculated in per history. And then you also have the mass energy transfer coefficient. As you can see that you have the transfer coefficient over the density, and then that's how you're able to estimate that. And then you also have the median energy bin, which is represented by E. And then there you actually have the conversion rate from air camera basically to the phantom, and then using an ICU slab of energy. And then those are the units in sieverts per gray. And then again, the depth is important, as I mentioned. And then in this case, we use 10 millimeters per depth to the operator. And then, yeah, as I mentioned, the I, it's how many, the bin energy in the spectrum. And then the spectrum is actually from 1 keV up to a certain amount and of kilo electron volts for the photon energy. Okay, this is basically the experimental setup used. So it's important to know that this study actually relies on available data from experimental intervention procedures, and it builds upon that data as well. So what we employ in the study, as you can see in the setup there, two types of dosimeters. First, an APD, electronic personal dosimeter, as well as TLDs, thermolucent dosimeters, and these were surgically placed on the upper torso of the CTU-41 torso phantom, and then that's the phantom basically that represents the operator. And the purpose, as I mentioned, is to estimate the scattered dose from the patient to the operator at a depth of 10 millimeters during an interventional procedure. So the radiation duct, so how the simulation softwares work is that they extract what we call a radiation dose structure report, which can be taken from any interventional radiology machine, and it incorporates that into the system. And then that will be the input for the MC tools to calculate the personal dose equivalent to the operators. And then the machine that we work with, that we're simulating, is actually a Siemens interventional radiology machine, and then that's an example of it there on the screen as well. So this is basically the setup, and then for both, as I mentioned, the machine was just Siemens Otis, And then such as the other parameters that we use in the setup can be seen in the table there.
So sorry, Joseph, to stop you now, but you had 12 minutes. Your time is over now. We should be fair.
Just last minute.
We had 12 minutes. 12 minutes. So
12
sorry.
minutes. Okay,
How
no,
much
it's not
time is
a
left for
problem.
you? How much is left for you? Can you end up in 1 minute?
I actually had 2 slides left.
And then please go on with 1 minute, please.
Okay. All right. Sorry. I don't know if you can hear me. Just that my internet is a bit slow. Okay. I'm gonna continue. So that's basically what we did. What we used these 2 equations here to estimate or to calculate the accuracy ratio, which is comparing the experimental to the simulation. And yeah, just straightforward simulation over measured, and then we're able to get the accuracy ratio. And then we also calculated the deviation ratio as well. And then the significance of calculating the deviation ratio is to show whether the simulation basically overestimates or underestimates the calculated radiation. And yeah, both quantities are expressed as you can see on the screen. The first one is accuracy ratio, the second one is deviation ratio. Okay. Okay, and yeah, these are the results of the simulation comparing basically the simulated results, as well as comparing the experimental to the simulation. And then of course we're comparing both softwares against each other, Penelope and MCGPU. And then again, as you've seen in the experimental setup, remember we're using 2 dosimeters, the APDs as well as the TLDs. So in summary, if you look at the results, the MCGPU has the largest deviation of almost 81%. And then the Penelope has a better comparison because with an average deviation of 19%. That's against the APDs. And then in comparisons to the TLDs, where we use the TLDs to measure the dose, there seems to be a better comparisons between the simulation using the TLDs and the PLDs. And then the deviation from both tools, it's almost the same. It's negative 19. So for some reason, from the experiment, we noticed that using the TLDs, the simulated results compared to the TLDs, we found that the tools actually underestimated the dose. And then the MCGPU had a better overall comparison of minus 11%. So in conclusion, if we can remember the results, it can be seen that the MC tools are supposed to exhibit similar patterns in simulating the Fresnel dose equivalent. And both tools currently may not be sufficient to replace the conventional method of calculating the Fresnel dose equivalent to the operator. But then I suppose these tools can be useful for radiological risk estimates, since studies reveal that interventional cardiologists are actually prone to head and neck cancer more than anyone. And then these MC tools can also be used to focus on head and neck and eye calculation, those calculations to the operator. And since Monte Carlo simulations are allowed to test several different scenarios, therefore, they may play a central role in procedural optimization, as I mentioned. And then these findings from such simulations can help us be able to estimate an optimal positioning during interventional radiology procedures, and also the operator height, which will be optimal for when performing these procedures. But then currently they cannot be used clinically, but then they can actually be used for educational
Okay,
purposes.
Joseph, excuse me. That was 5 minutes more already. Thank you very much for your talk. because we need to keep our time plan. Yeah, excuse me that I need to stop you. Do we have some questions to Joseph now and his talk? Some questions? Okay, Joseph, then I would have one question to you. I know from the statistical physics there is the so-called binder parameter. Can the binder parameter also be used for calculating the effective dose?
Okay.
Yes? Did you hear my question?
I heard you speaking about the binder parameter.
Yeah, the binder parameter. Can it also be used to calculate this dose, effective dose?
Binder parameter. I'm not sure. It's actually the first time I hear about.
It's the first time you hear about it. It's a parameter in the statistical physics. That's why I
okay.
thought maybe you know about it. Okay.
All right.
Good. Thank you very much for your talk.
Thank you so much.
So let's go on to the third participant of the second session. We now welcome Mutambi Atega from Uganda. Hello, can
Yes,
you hear
I
us?
am here.
Hello. How are you?
Yes, I can. Yes, I can.
Okay. Mr. Mutambi is a medical officer of imaging department, Beloa Healthcare Center. And the topic he's speaking now to us is multimodality imaging application in brain tumor radiotherapy planning. So, please, if you're ready, the stage is yours.
I'm requesting if someone can help me project my slides because
Your slides are in full screen seen to us now, shown to us. So,
okay.
Please.
Okay, please give me a second. Sorry about that. Sorry, that's give me 1 second. Okay, can you hear me?
Yes, we can hear you.
Okay, so I'm talking about multimodality imaging application in brain tumor radiotherapy planning.
Она, к сожалению, туда не поворачивает.
Куда нам надо сесть, чтобы было?
Вот сюда, вперед.
На первую?
Да. Ну, короче, она смотрит вот сюда, вперед.
Первые ряды.
Hello, Mutambi, are you with us at the moment?
It seems to me he's not online.
It's all, yes,
Yeah.
I think so too.
Он подключен, и звук включен.
Mutambi, do you hear me?
Yes, please.
Can you continue, please?
Okay, please, next slide.
So you can just rule the process. Ask Miss Nadezhda to help you list the slides when you stop, okay? Just make it a free discussion, okay?
Okay.
Because I can't hear you very
Okay.
well, unfortunately.
Okay.
Maybe you are speaking, but we cannot hear you.
Okay. Can you hear me now?
Here, but just
I am.
with some difficulties.
Hear me now? Sorry.
A bit louder,
I think
please.
it's my net.
A bit louder, please.
Okay, please. Can you hear me, please?
Yes, yes, please. Okay, come on, come on.
Okay, so next slide. That's the aim of this research. It's to study the possibility of multimodality imaging using SPECT CT with a radiopharmaceutical, which was new, technetium-99 1-thiodeglucose. And those were our objectives, basically to study how to use the systems, then do the delineation, then compare the clinical volumes delineated using the different imaging modalities. Next slide. So we used CT scan.
Я понимаю, как ему сказать.
Ну, вот сейчас в онлайне коллеги пусть ваши свяжут, чтобы он, если на себя инициативу по презентации берет, тогда пусть сам объясняет, что следующее.
Dear colleagues, we hear your voices. Excuse me, please. We don't understand what is going on.
Мы не слышим. И он сам крутит слайды в обратную сторону.
Mutambi, please.
Yes.
Please give me the signal that you hear me, first of all. And there is the problem with the slides. You are listing the slides. You ask Miss Nadezhda to list the slides, to move the slides for you. So please do not use the slides then. To make it synchronous work, okay?
Okay.
There must be somebody, you see one person who will be moving the slides.
Okay, please. Okay, so yeah, the specs here, we administer the radiopharmaceutical and it's absorbed in the tumor, and then we're able to use the gamma cameras to image and see the position of the tumor. Next slide.
Он уже сам это делает.
I cannot see the...
Mutambi, this slide, the current slide, which we see on the screen now.
Он сам это делает.
I cannot see the next slide.
Number 6 slide or number 7? Which slide? Mutambi. If number 6, we see it on the screen at the moment.
I think that my internet is very bad.
Ну, это понятно, но только зачем он сам это делает?
Maybe we will stop now, Mutambi. And we will give the floor to another speaker when you are trying to solve your troubles. Mutambi, what do you think?
No.
So you would like to proceed? right? Надежда, давайте мы дадим предложение слова другому выступающему, Сэмюэл, пока Мутами будет решать свою проблему. Хорошо, чтобы время не тратить.
Pardon?
So, Samuel, now.
So, Dr. Hagus, are you with us? Can you hear us? Dr. Hagus? Dr. Hagus don't react. So, okay. Good. Then let's go on with the next participant, number 4 on our list. Please let me introduce to us Samuel Jo Asemea from Ghana.
Yes.
Samuel is a graduate of School of Nuclear Science and Engineering, National Research, Tomsk Polytechnic University. And he will speak about improved methods and technology for radiation therapy and diagnostics. So Samuel, are you ready?
Yes, I'm ready.
So then the stage is yours, please.
Thank you very much for this opportunity. And as already introduced, my name is Samuel, and I would like to talk about some improved method technologies in radiation therapy and diagnostics. Now, currently on the slide, what we have here is just the outline on what I will be talking about. Next slide, please. Okay, what is the relevance of it? Now, we know that cancer remains the leading cause of death globally. And the International Agency for Research on Cancer recently estimated that 7.6 million deaths worldwide are due to cancer. For that matter, in order to reduce this and also the damaging risks and give healthy surrounding healthy life to people, there is a need to use radiotherapy. And here I want to talk about the new innovations being done or being introduced in radiotherapy. Next slide. Methodology. What I did was I used a comprehensive research conducted from the International Atomic Energy Agency publications, Google Scholar, and other research papers in my work to come out with this research. Next slide. Okay, yeah. We all know the traditional radiation therapy, which is just involving the use of high energy radiations to kill cancer cells. And there are two types. We have the external beam radiation and the brachytherapy, which is the internal beam radiation. But despite all this, there are some limitations with this. For that matter, there is a need for some improvement. Okay, what are some of the examples of these limitations? For example, maybe a tumor may be located in an area where it is very difficult to target and irradiate. That is why these improved methods were employed or were being employed to help in radiation therapy. Next slide. Okay, one of these improved methods of radiation therapy and diagnosis is the spatially fractionated radiation therapy, the SFRT. Now, the SFRT is a radiotherapy technique that allows for the delivery of relatively high but varying doses of radiation across a large tumor while protecting the healthy surrounding organs. Now, with the SFRT technique, there is also another sub-technique we can use under the grid radiotherapy. Now, with the grid, we use physical block, which is small holes that allows a tumor to receive a combination of high and low dose of radiation. Then also we have the lattice radiotherapy under the SFRT, which also it's been achieved by a similar effect by just using a computer model. And in 2020, April, IAEA initiated a coordinated research activities on the efficacy of the SFRT in treatment of lung and cervical cancers. Now, another method is the image-guided radiation therapy, IGRT. Now, this technique uses advanced imaging technology to guide radiation treatment in real time. And with the IGRT, it allows for room or maybe more accurate targeting of tumors, targeting of tumors that may have been shifted or maybe changed in position since last treatment. And with the IGRT also, sometimes treatment margins might become tighter and maybe more conformal. And for that matter, the potential to miss a tumor to an organ motion and a patient setup is more greater. That is why this technique has an imaging. So at the same time, in the process of diagnosis, there is imaging to guide the whole issue. Now, IGRT also allows detection of such errors or maybe errors in when it comes to motion, because maybe patients might be moving or there are some motions, and it also helps when it comes to motion and helping identify all these errors. Next slide. Yeah. We also have the IMRT, the intensity modulated radiation therapy. It's also one of the cutting edge technique that allows more precise targeting of cancer cells while minimizing the surrounding healthy tissues. Now, the IMRT is achieved by using multiple beams and of varying intensities that conform to the shape of a tumor. And the result here is higher dose to a tumor and then lower dose to nearby healthy tissues. And for that matter, the IMRT also is being employed based on the inverse planning software and as a computer-controlled intensity modulated of multiple radiation beams, as I said earlier on, because there are varying beams of different intensities that is being used here. And this IMRT, it also allows improvement in therapeutic ratio for several tumor sites, such as the head, the neck cancers, and prostate cancers. So the image here we see here is telling us how the IMRT is being administered. The next slide. There's also another technique or method, which is a stereotactic body radiation therapy, SBRT. Now, the SBRT is also a technique precisely which delivers high individual dose of radiation over only a few treatment fractions to ablate a small tumor. Now, due to the high radiation dose, any tissue immediately adjacent to tumor is likely to be damaged in terms of radiation. However, as the amount of normal tissues in high dose region is small and non-eloquent, maybe clinically significant toxicity is also low. So with the SBRT, shows excellent results in treatment of early stages, especially in early stages, and also a non-small cell in lung cancers. We use the SBRT. So the diagram here also shows how the SBRT is being administered. We could see a target in the brain and also how this fraction of what dose are being targeted onto the target in the brain. Next slide. Now we are talking about improved methods in radiotherapy and diagnostics. We can't also forget about the innovative technologies which are also transforming the field of radiation therapy, especially in imaging. Now in PET, the PET or PET-CT can be indispensable as a diagnostic and also a prognostic tool in assessment of patients to a therapy and also a cancer occurrence. Now, the introduction of the digital photon counting technology in PET has really improved the patient's experience and is still ongoing. And also the time of flight has also been improved. Then also, not forgetting about MRI too, there has been some also new innovations in MRI. That is the introduction of the biometrics technology. Now, this biometrics technology centers on the perfect symbiosis of power, intelligence, and speed of images, and also how sharp images are. And aside to, there has been some incorporations of AI into what? Image reconstruction technology in MRI. Next slide. Great. So what we have here is a digital PET scanner from Philips Various PET scanner. And we know that the scanner has a digital features, and there has been a digital detector being built into this scanner, and which helps in the sensitivity of images and also the time taking. It also helps in the time taking. Now, when I talk about sensitivity in the sense of the image quality has been improved. Well, now all digital PET scanners, digital PET scanners has improved image quality, and also consequently the detector built in is also helping us to also detect for small lesions when we use the digital PET scanner. The next slide. So here we have images of PET that we want to compare. Now on the left, we have the oncology whole body comparison of an analog and a digital PET scan. And also on the right, we have a 90-second brain acquisition image which was acquired with the fluorodeoxyglucose radio tracer. And we also want to compare both the analog and digital. So on the left, you could see that the analog images are not that clear as compared to the right image of what? The digital. Now, why do you want to compare the digital and analog PET scans? Now, the major difference between the digital and analog lies in the projection and also the LCD televisions. Now, the digital architecture delivers a very sharp images and higher efficiency and also more dynamic images. So on your left image paired, you will see that the very left one is an analog image, and then the immediate right is a digital one, and we can see how the images look like. Then on our right too has images of the brain, and also we could see that the left one is a digital image, and also the right one is also the analog image. Now, what happens to the digital and analog imaging in PET is that now in analog, the light generated is being done by a single scintillating crystal, and which is also channeled in a multiple photometer tubes. But in digital, it's just a single light generated, which is channeled into its own detector. And for that matter,
Samuel, sorry to interrupt you. You had 12 minutes now for your talk. How much is left for you?
Just 2 slides.
2 slides. Can you do the 2 slides in 1 minute, please?
Yes. So next slide.
Please, yeah, Samuel, do it. Thank you very much.
Okay. Okay, so here we have MRI. So this an MRI scan, an AI-powered 3000 magneton reader produced by Siemens, which also has a biometrics technology. And what does a biometrics technology does? Now we know that motion is a very challenging MRI, and it dramatically decreases the image quality and also limits consistency. So with this technology, when it comes to, it has some sensor which captures motion. especially with the heartbeat and any movement organ in the body when we want to take an MRI scan. So these are images of taken by the vital sign. These are also images taken by this is a deep resolve MRI scan of the knee joint, very high quality image. Now here we also have an MRI scan of the head and neck. Now with this technology of biotuners incorporated in MRI, we could see that we compare the conventional MRI scan and the biotuner, or which we use the coil shims to take the image. There is a far difference. Now you can see an arrow somewhere there. The arrow tells about high signal, but when we incorporated the technology of coil shim, we have a low signal, and which is also good. Thank you very much. And in conclusion, we can say that radiation therapy plays a vital role in cancer treatment, while traditional methods have limitations and challenges. Improved techniques also really help, and it has shown a great promise for the future of cancer treatment. Thank you very much.
Thank you very much for your talk, Samuel. Do we have some questions to Samuel? So it seems we have no questions to you, Samuel. So, yes? Okay. So, Samuel, thank you very much for your talk.
Thank you very much.
Dr. Haggis, can you hear us? Are you here now? Hello, Dr. Haggis?
Ask him to switch on the microphone.
Dr. Haggis, please switch on your microphone.
А кто это?
Yeah. But you need to switch on your microphone. Please, Dr. Haggis, you need to switch on your microphone. I cannot do it for you. Just go to the symbol and switch it on, please. Okay, we are running short on time. It seems we have still technical problems, Dr. Haggis. So let's go on with the next participant. Let's welcome Edmund Joseph Chomba from Tanzania to us. Edmund, can you hear us? Are you here? Edmund? Are you here? Hello?
Edmund, disconnect.
Yes, yeah. I can also see this slide from him. Edmund, please say something.
Есть. Вот оно. Есть. Я его сделала, выслала приглашение в эфир. Все. Но я не знаю, что сделать.
Samuel. So.
Edmund is connecting now. He's reconnecting. He's writing. He's sending me the message.
Should we wait for him?
Maybe a couple just of minutes.
Or we go on this next one?
Maybe just a couple of seconds. Yes, maybe just 10, 15 seconds, right? Надежда, вы видите Эдмунда сейчас?
Да, я его вижу, он подключен как ведущий.
Пишет, что он подключается опять вновь.
Он уже 4 раза отключался, подключается.
Скорее всего, что-то с интернетом в Танзании.
Да,
Я думаю, что только это причина. Он так долго подключался к этому процессу.
Он просто входил с 2 аккаунтов, остался один, и что-то у него не видно устройств. Я думаю, что он просто не подключил свое устройство.
Может быть, мы сначала... Sven, shall we continue with David, Jonathan David, Neoni, maybe, right? While Edmund is solving. Or maybe Mutambi, yes. Mutambi, are you still with us? Mutambi, do you hear me?
Включить микрофон нужно ему.
Actually, I checked the list of the participants and I can't find Mutambi Atageka. You see here? Yes. Mutambi, could you please switch on the microphone?
Okay.
Okay. So are you ready to proceed the presentation that you have started?
Yes, but my internet is not good. I don't know why. That's
okay.
The slides.
Now we are waiting. Yes, this is the beginning of the presentation. While the internet is good, you can proceed.
I can't see the slides.
You cannot see the slides?
It takes very long to load the slide. No, I cannot.
Ну зачем?
It's Mutambi. Can you just present your
It takes very long to load the slide.
Okay, you just can accompany the slides which we see on the screen with the report that you have prepared for today, okay?
Okay.
Okay, just begin from the very beginning. Sorry for the repetition, but I think that will help you.
Okay.
So tell us briefly, what is the research title of your presentation, what you have prepared, yes?
Okay. So multimodality imaging application in radiotherapy planning. If you can please go to slide number 8. Are you there?
Yes, number 8. Yes.
Yes, so we had to mark the volumes of the tumor using the recommendations, the protocols of SENS, and we were looking at the volume of the tumor and the volume of the cavity for those that had been operated. Slide number 9.
Okay.
Yes, so we had to use those 4 different imaging modalities. We used CT scan, we used MRIT1, MRIT2, and SPECT-CT. That is getting the SPECT image and join it with a CT image. And from this specific patient, we can see the difference in the volume of the different, using the different images. We can see that for CT scan, the volume was very big. And that is because CT has bad, poor soft tissue contrast. So it is very hard for you to know that, okay, here it is edema and here it is the tumor. So you end up having to include the volume. you end up having to include a big border so that you don't miss the tissue. And when we used SPECT CT, we could see the exact dimensions of the tumor. So at that, we are able to have a smaller volume. Next patient. Next slide.
Okay.
Yes, we can also see there's a difference in the tumor volumes. And now in this case, we noticed that there was a big volume shown on specs as well. But when we look at the tumor at the standard uptake value, which shows us the real activity, we actually found out that this was mainly a cavity without a tumor. So with there we end up giving a lower dose because we know that there's no tumor, it's just the tumor cavity. So if we are to give a boost, we're able to reduce the dose and save, the functionality of the patient, which we couldn't do if we couldn't know if we did not use the SPECT CT. Next slide, slide 11. On slide 11.
Надежда, у нас не та презентация идет.
Почему? 11 слайд.
Нет, многие уже участники говорят, что не та презентация, и что он использует презентацию другого человека.
Если честно, ничего.
Тематика не совпадает.
Вот так, извините, это...
Mutambi, excuse us, so sorry for the Russian, yeah, because some of the participants have indicated that the presentation is not the one which needs to be demonstrated on the screen at the moment, you see? There is some kind of mistake.
Это его презентация?
Надежда, он не видит ничего, он только слышит нас, он не может сказать, что это его.
Хорошо, вот я просто листаю до первого слайда. Да, на первом слайде
у него multimodality.
А Мубита Дэвис это он?
Нет, он не Мубита Дэвис, он от Агека Мутамби. Davis will be performing at the end of today's meeting.
Ничего не понятно.
То есть это вот сейчас вот это его работа, Мутамби Агека.
Теперь понятно, да. Почему мы все не понимали, о чем речь?
Да, вот в чем причина, наконец-то выяснили. So now we have find out, you see the problem. Excuse us, Mutambi, please excuse us. Now we have this presentation, multimodality imaging application and brain tumor radiotherapy planning. We are very much sorry for misleading the participants of today's event. And now, so we can open the slide 11, right?
So can we start with slide 9?
9, okay. I will help. Надежда, я покручу сама.
Can we see slide 9?
Yes, please. We see this.
Yes, so from this slide, as I was saying, we took images for the brain using the different imaging modalities, and we used the recommendations given by SCNS to make sure that we delineate the tumor volumes. And from this, we can see that there is a difference in the volumes delineated using the different images: CT, MRIT1, MRIT2, SPECT CT. We can see that with SPECT CT, that the volume was a bit smaller, because we knew from the activity we could see where the tumor was, and we could know that this is where it stopped. And with CT, because of poor tissue contrast, the volume had to be bigger. So we can see that we end up radiating the part of the brain that actually has no tumor, simply because our imaging modality has poor contrast. We can't know the end where the tumor stops. Slide 10.
Кто мотает? Я?
Yes, so on slide 10, we can see that the tumor volumes were almost, were not so much different, but significantly from this scale we see on the side, which is the standard uptake value scale, we actually found out that the region that we see with a high uptake actually has no tumor value, because we use the standard uptake value and there's a maximum value where we know that, okay, if it's above this value, then we know that there is actually it's the tumor activity, because the activity can be in other parts without tumor activity, but to a lower level. And here we're able to know that this is actually mainly the tumor cavity and fluid in the tumor cavity with some edema surrounding. So we are able to judge which dose to give because of the information we get from SPECT-CT. The next slide. In the next slide, we are also able to differentiate between a cavity that has no tumor and the region with tumor that was left after surgery, which is very hard to see, for example, on MRI, FLAIR, and on CT images. So now there we could also see that with SPECT-CT, we get more information than we can get without SPECT-CT.
Because we have
so summarize the benefits on slide number 12.
And no questions, yeah.
Slide number 2. Какой?
Slide number 12. Well, yes, 12. We can see the contributions of the different imaging modalities according to our project. CT is mainly important for electron densities, which is applied in calculating the dose. But it has a limitation in soft tissue contrast, as we have seen in the patients we worked on. Then MRI has good tissue contrast, but its geometry is not so much trusted. And SPECT is able to give us information about tumor activity, which is very important. And in this case, we can say that the new radiopharmaceutical technetium-99 thiodeglucose is good for our role in brain tumor imaging for radiotherapy planning. Yeah, and the recommendations which we were able to give for accurate target volume delineation, it's good to use all the imaging modalities, and they should be taken at least in a period of 5 days, not more than 5 days apart. Then after treatment, we can do evaluation using SPECT because it's available, but also MRI is good because it has good soft tissue contrast, only that sometimes it's not as cheap.
Mutambi, excuse me that I interrupt you, but we have only 20 minutes left and 3 speakers are now. So sorry, we need to break up now. Thank you very much for your talk. And we go on with Davis.
Hello?
Mubati from Zimbabwe.
Hello?
Zambia, excuse me.
No, Jonathan David.
Huh?
Jonathan David Neone.
Jonathan
Hello?
David.
Yes.
Что, Джонатан Дэвид?
Ah, Jonathan Davy. Ah, I understand. Excuse me. Jonathan, can you hear us? Hello, are you here? Because I cannot see Jonathan online.
Hello?
Я не слышу.
Hello?
Jonathan, are you with us? Do you hear me? Please switch on the microphone so that we could hear you. I can't understand. He says that he's online. Надежда, а мы вообще видим Джонатана?
Вот я его и смотрю. Не очень вижу.
Потому что он мне пишет в сообщениях, что он онлайн. И он нас слышит хорошо.
А смотря под каким именем, кто ж его знает. Это Джонатан Дэвид Неоне?
Да.
Я его не вижу. Может быть, он висит где-нибудь? Тут комната.
We shall go to another participant.
Есть Дэвис Мобита, это не он?
No, Davis Mobita is a different person. He would be finalized in today's session. So Надежда, вы не видите Джонатана Дэвида, да, в списке сейчас?
Нет, вы видите? Мы, в принципе,
я вот смотрела, я не вижу действительно.
И я тоже не могу.
По крайней мере, по тем именем.
Вот и мы не видим.
Dr. Sven, maybe we shall continue with another participant, Andrea.
Может быть, он руку поднимет?
Hello.
So we have on the list Edmund. Edmund, are you here?
Yes, I hear you.
Okay, Edmund, then let's go on with your talk.
Okay.
So let me introduce Edmund Joseph Huma from Tanzania. He's a PhD student of the Research and Training Center for International Nuclear Education and Career at the School of Nuclear Science and Engineering at the Tomsk Polytechnic University. The topic of his talk today is improved methods and technologies for radiation therapy and diagnostics. Edmund, please go on.
Да?
The stage is yours.
Okay. Slide, you click slide number 1.
So we shall move the slide, yes?
Yes.
Okay. Now everybody sees slide number 2. Edmund.
Yes.
Okay, continue, please.
I'm waiting to see the slide page. I didn't see it.
You do not see the slides?
Slide 3. It's slide 3.
Yes.
Slide 3? This one?
Yeah.
Yes, of course.
Okay.
No. Yes, this one.
Thank you.
So, good afternoon.
Good afternoon.
So this is my presentation concerning the improved method and the technology for diagnostics and the radiotherapy. But the main project based on radiotherapy in 80%, because the treatment of cancer by using radiation therapy, it depends on diagnostic modalities. The cancer treated. Hello?
Yes, please.
So the treatment of cancer by using ionizing radiation started 1 year after the scientist Roentgen discovered the X-ray. So the exact period started in 1896 up to 19th century. So during that period, the modern techniques, especially for external beam radiotherapy and the brachytherapy also developed for cancer treatment. At that period, the cancer treated by using the superficial voltage and also voltage. So you can go on slide number 3. Hello?
Yes, yes. Shall I move the next slide?
Yes. Slide number 3.
Okay, very good.
Это я, извините.
So in this slide, based on the method and technologies for diagnostics, the main point here is the modalities that are used for diagnostic cancer. So the first one is a CT scan. CT scan is the one of the imaging modalities used to analyze or examine the internal part of the body. But the capability of CT scan, it doesn't show the affected, of course, on a soft tissue. So the improved from the CT scan to MRI, one of the advantages for MRI to display the soft tissue during the analysis. But the problem for CT scan and the MRI, it produces a black and white images. So the MRI spectroscopy is another modality for medical imaging that used in many hospitals or centers. The one of the advantage here, it produces the colored images compared to the CT and the MRI. We have a safety analysis. This is a radionuclide imaging that use the radioactive material to display the internal part of the body. The problem of this SPECT, it show actually it produces the image in a 2D dimension compared to the PET. PET is a more advanced medical imaging modalities because it uses the metabolic process and the metabolic radioactive to display the image on the body. But one of the problem in PET, not all images in PET can be either detected, it can be displayed either as a only cancer or other disease, but it shows the images or the disease at the initial or early stage in the molecular part compared to the CT scan and the MRI. But the PET CT scan, this is a more advanced modalities for cancer, for diagnostics, because it can analyze the disease in terms of radioactive distribution and the beam attenuation. So the one of the function CT scan, it produces the image according to the attenuations of radiation, but the PET, it produces the image according to the radio distribution. But the combination of the PET and the CT, it produces the another different colors of image. So you can go on slide number 4. So during the period of a cancer treatment, the technology is improved every year. Before the new technology of treatment of cancer by using megavoltage X-ray, in the 1886 century, we are used the superficial and also voltage, that is the kilovoltage machine or treatment modalities, but they can't have penetrating power to the tumor or region that is located very far from the skin. So the new modalities involved the new technology. So the new technology that we have now to use a linear accelerators that use it to generate the megavoltage electrons. So in this slide, we have you see that the different ring accelerators in the CM and the cycle rings, both are used for cancer treatment in the different energies. So also we have a cyber knife that is a new and the best method for cancer treatment, especially for cancer located to the organ at risk, which are moving, or cancer located in the organ always are moving. So it's cyber knife is a better method for treatment of cancer in motion. Slide number 5. Hello? So in this slide number 5, just I need to explain the treatment techniques. During in cancer treatment, especially in different departments, we have different modalities for cancer treatment. We have a 3D conformal, IMRT, VMRT, and the ACBRT. Simply and clearly, 3D conformal radiotherapy does not generate modulated beams. The function of the modulated beams, it produces the beams according to the shape and the size of the tumor, and also it is separate between the target and the organ at risk. The problem between the CT and the IMRT, according to the dose distribution. The dose distribution in IMRT, that intensity modulated radiotherapy, is more advanced compared to the 3D conformal radiotherapy. Then also volumetric modulated arc therapy, VMAT, actually it produces a more conformal dose compared to IMRT, compared to the 3D conformal radiotherapy. But the difference in the dose distribution, how to spare the dose between the organ at risk and the PTV, that is planning target volume. So VMAT, it is spare low dose to the organ at risk compared to IMRT and the 3D conformal radiotherapy. And the new technology for steno beam treatment planning, we have stereotactic body radiotherapy, SBRT. This one, it generates the beam in the case of a small fields that it produces the dose actually in exactly specific compared to IMRT.
Edmund, sorry for interruption. You have 1 minute, just last minute to finalize the presentation, please.
Okay.
Excuse us, please.
Go to the slide number. Go to the another slide.
Thank you.
So this slide, it involves the impact of the improved method and the technology. If you see the two images, we have the left one, it shows the full distribution of dose in a specific organ. This is a prostate. But the second one is a 3D conformal radiotherapy. It shows distribution of dose in different areas, including to the organ at risk. So the improved technology, it is very important for dose distribution during the treatment planning or during the treatment of patient. Go to the another slide. You can move to the another slide because this one is not necessary.
Еще another slide.
Еще дальше.
Go to the another slide. So one of the challenges that we have in a department of radiotherapy. Hello?
Что, да?
Edmund, yes, we hear you.
Yeah. Okay, Edmund, thank you very much.
In conclusion,
we need to finish now. We have only 15 minutes left. So the next one is Jonathan. Jonathan, are you with us? Can you hear us? Please speak, Jonathan. Jonathan David, are you here? Are you online? You're on the participants list.
Он есть, но устройства нет у него. Он как бы подключен, но у него ни камеры, ни звука нет.
Необычно.
Во, подключился.
Jonathan? Hey, hello, Jonathan. So, can you give your talk now, yeah?
Yes. Do you have my slide on transforming medical imaging diagnosis with nuclear energy?
I cannot hear anything. Okay, Jonathan, I will introduce you now. So our next speaker is Jonathan David Nyawi from Zimbabwe. He's a master's student of the Midland State University. And his talk today will be about transformation, medical imaging diagnosis with nuclear energy, pattern recognition in large data sets of PET, CT imaging using machine learning techniques. Jonathan, please go on. The stage is yours.
Thank you. I will start presenting my title. I would like to thank you firstly for this opportunity. So my title on this presentation is recognition in large data sets of PET or CT images using machine learning techniques. And of course, the main objectives of this research title is to transform medical imaging diagnosis with nuclear energy. If I may ask, are you hearing? Are you hearing me?
Yes, we are. Yes.
Yes.
You are?
It's okay, Jonathan, do not worry. You can continue. We hear you very well.
Oh, thank you. Can you move on to the next slide?
Yes, please.
Yes. There's the next slide. I'm trying to show the PET or CT image machine. So this thing is called positron emission tomography. It's shown. This machine was designed using a new deep learning image processing. So as you can see, there is a computer there which is showing a computer program that is being used to analyze the images which are being produced by this PET CT. So the idea, if we go on to the next slide, you would realize that I would like to discuss about the use of radioactive materials in medical imaging for disease diagnosis and treatment. So as it has been reported already by the Russian nuclear medicine journals, it shows that the PET and CT scans can provide detailed images, but they can be subjective and time consuming. So as we can see on that image, on slide number 2, we can see that there is an image there. So you can see that there's an image that is being detected by that artificial intelligence program using certain artificial intelligence and machine learning algorithms that were trained using a very large amount of data sets so that we could increase the accuracy. So we can move on to the next slide. We may use artificial intelligence to detect the earliest signs of pancreatic cancer. So in this case, we've got an artificial intelligence tool. So it's a research that I took that had already been done using that artificial intelligence tool. So now my research is now focusing on these results that has been produced by this artificial intelligence tool, so that we can now be able to read these scan in early stages of appearing of a disease. For instance, in this case, I'm taking pancreatic cancer. So we can see that using a human eye, you may not be able to read the results properly, unlike if you were to use these algorithms, because they are capable of reading these results even before when it's visible. So as it was said by Tusif Ahmad Qureshi, he was hoping that this tool would catch the cancer early enough to make it possible for more people to have their tumor completely removed through the process of surgery. Why would we need this information? It is particularly needed as it highlights the benefits of the benefits and challenges which are currently associated with their implementation. And it can also help us in the improvements in accuracy and even the efficiency which are brought about by these algorithms in decision making by professionals which are in healthcare and radiography. So if we move on to the next slide, on slide number 8, you can see that I'm now looking at the knowledge gap, the current technologies, what is lacking in these technologies, right? So we can realize that there's been the use of traditional diagnostic methods. And I'm now comparing these traditional diagnostic methods with these recent scientific technologies, whereby we use machine learning and artificial intelligence as it can improve accuracy, and it can also reduce the interpretation time by recognizing these patterns in large data sets. So in this research, I decided to take different methods and materials to search. We took the search strategy and inclusion criteria. So particularly took a look at different electronic databases, and I searched these databases using keywords such as nuclear medicine, positron emission tomography or computed tomography, imaging, machine learning, and they were taken from a range of between 2016 and 2023 that were published in English. So the data was extracted and synthesized to try and identify the common themes and trends in the use of artificial intelligence. So as a result, we realized that there is a very big potential of machine learning and artificial intelligence algorithms, enhancing these accuracy and reducing interpretation time. I can't hear you.
Slide number is now.
Здесь нет нумерации, я не знаю, какой.
Jonathan, you need this line. The slide which is shown on the screen now. Continuation, why information is particularly needed, yes?
I'm now on results. The slide number 10.
Mm-hmm.
Yes, slide number 10.
But we have here a slide more in emphasis, overview of existing literature on nuclear medicine.
Can you go on slide number 10?
Because your presentation is not numbered.
Okay.
Materials and methods or just results? Results, yes?
Yes, results.
Yes, results. We see the slide, please.
Yes, I was taking a look at these results and we realized that there's a very big potential of machine learning and artificial intelligence algorithms in enhancing accuracy and reducing the interpretation time. So, for instance, we took this example in the improved performance in diagnosing pancreatic cancer and predicting of coronary artery disease. In the recent studies that was done by Kui and as I had mentioned in the first slide, you would see that there was at least a percentage of something like, which is above 90% of accuracy, which is better than the ones which are being used by human beings. So as we can go to the next slide on discussion. So we can realize the role of computer programs on these large positron emission tomography and computed tomography image datasets. So there is a promising result and implications for personalized treatment plans and patient outcomes. Although there are challenges and considerations that we may take a look at on this research, such as high quality data sets which are needed, and we also have algorithmic biases, and we also have some ethical concerns that you may want to take a look at. So we can move on to the next slide. So the next slide is on conclusion. So in conclusion, I would like to say machine learning and artificial intelligence algorithms show that there is a promise in improving nuclear medicine diagnosis and pattern recognition although there is also a need for further research in these areas, even if we were to look at its potential in clinical utility. So I appreciate you so much for this opportunity to participate in the International Youth Forum in Africa. Thank you.
Thank you.
Jonathan David, thank you very much for your talk. It was nice that you was able to join us. Also, this you had your problem with the internet before. So, but do we have some questions to Jonathan now? Please ask your questions.
No questions. Thank you. Let's go on.
No questions. We
No
see
questions.
questions
Okay.
from our participants.
Okay. Jonathan, thank you very much. Have a nice day.
Thank you so much.
We're going now to our last speaker of the second session. Let's welcome to us Davis Mubati. Davis, are you here?
Mubita.
I'm here. I can hear you clear. I hope you are able to get me.
Hello. Hello, welcome. So let me introduce you first shortly. Davis Mubati is from Zambia, and he's a lecturer and the Radiation Protection Office of the University of Lusaka. And the talk he's giving today is about the production of Lutetium-177 radionuclide by chromatographic methods for nuclear medicine at the research reactor. So, if you're ready, the stage is yours.
Okay, thank you for the introduction. So to begin our discussion, I would like to look at the next slide. So this is the content of our discussion. We'll look at the relevance of this research, the goals and objectives. Then we'll also look at the theoretical and the experimental aspect of this discussion. Then the finances involved and the dangers a researcher should be aware of. Then we'll conclude our discussion with recommendation if anyone would wish to take this research in future. Please, you may go to the next slide. So to begin with, how is lutetium produced? Lutetium-177 can be produced in the research reactor basically by two methods, direct or indirect methods. Indirect is based on the neutron irradiation of enriched ytterbium oxide and ytterbium oxide targets, while on the other hand, the other method, the direct method, involves neutron capture of enriched lutetium oxide target. This research will focus on indirect approach. Lutetium-177 has a, sorry, you have taken away the slide. I can see. I'm seeing a different slide here. Excuse me, I can't see the slide. Okay, thank you. So I was saying that this research focused on the indirect method. So lutetium-177, as you can see from the slide, it has a very short half-life of 6.7 days and maximum beta and gamma energies of 0.5 and 0.1 mega-electron volts, making it suitable for imaging in nuclear medicine. We can look at slide number 4. So the question is, how is lutetium-177 used in nuclear medicine? So as you can see from the picture here on the slide, in nuclear medicine, lutetium-177 is used as a radionuclide to treat cancer and metastatic diseases. The patient is initially given gallium-68 or fluorine-18, which binds with prostate-specific membrane antigens, PSMA, a protein located in the prostate. Prostate cancer cells are examined using PET, as you can see on the second top picture, or CT scans. And the scan can be done around the body to identify the location of the cancer. After that, lutetium-177 is given, and it will bind with the prostate-specific antigens and destroy them. Lutetium-177 dotatate is used also to treat digestive system including the stomach, pancreas, and intestines. We may look at slide number 5. So in slide number 5, why is this research important? So we see the relevance of the research. So there is an increase in cancer cases, therefore there is need to revamp production of radionuclides that may be used in the treatment of cancer. So between 2015 and 2017, there was 41% global increase in prostate cancer cases, and I believe Russia is not an exception in this regard. Therefore, there is need to increase the production of lutetium-177 so that we can meet this high skyrocketing demand. So this research provides the framework for producing lutetium-177 for nuclear medicine. We may look at the next slide. Please, okay. So here, the next slide just shows the goals, and I think you can see on the screen. We can move to slide number 6, which is more important. Slide number 7. So slide number 7. Okay, so here we see the experimental aspect of this research. Figure 1 shows lutetium-177 use as a function of the duration of radiation with thermal neutron fluxes of different densities. The theoretical results show that lutetium-177 integral yield depends on the number of irradiation cycles and on the amount of lutetium present in the target material. Dose rate decreases significantly with increase in distance, as you can see on the graph on the right-hand side. So we may go to slide number 8. Slide number 8, thank you. The total average absorbed dose was found to be 2.74 kilogray, which was far much less than the theoretical value of 1 megagray. If the total average absorbed dose is greater or equal to 1 megagray, major changes in the resin characteristics would occur and the resins will be damaged, and therefore they may not be used in the experiments. So we go to slide number 9. So now let's look at the things I did throughout my research. The process began by irradiating enriched ytterbium oxide and lutetium oxide with thermoneutron fluxes of various densities. The purpose was to obtain lutetium and ytterbium tracers that would be used, that would be combined with natural lutetium and ytterbium in an ion exchange column to separate and acquire the necessary therapeutic lutetium-177. The pictures here summarizes the steps which were involved, as you can see on the slide. So we can go to slide 10. Now, the big question I want to answer is what substance is used to separate lutetium-177? Well, we use ion exchange resins, and that's what you can see on the top right of the picture. Ion exchange resins are quite easy to prepare. So the first step, you have to use deionized water to remove impurities. Then in sections, transfer to the column and wash with sodium hydroxide, distilled water, and hydrochloric acid. So when the resins are ready to be used, then they can be transported to the column so that the separation can be done in the fraction in the ion exchange column. We can go to slide number 11. Since the ion exchange resins are ready, now we can perform the experiment, and that's what you are seeing here in this picture. Figure 3 shows the simplified chromatographic technique. Pump 1 provides alpha iboxybutyric acid or HIBA acid to the column, while pump 2 delivers lutetium and ytterbium tracers to the column. In the column there will be elution taking place. Pump 2 receives eluids from the column and delivers the collection fraction containing a lot of test tubes. Impurities are collected in separate test tubes, and 99% of lutetium and ytterbium may be obtained if the separation is done successfully. Slide number 12. So after successful separation of lutetium and ytterbium, 2 separate peaks were obtained with the help of a gamma spectrometer, and that's what you are seeing there. The degree of separation, which is expressed as the resolution of 2 peaks, was greater than 1, a clear indication that the separation was complete and successful. Slide 13. Exchanging sodium ion for hydrogen ions, which is originally bound to the resins, may be used to determine ion exchange capacity. The equation demonstrates how this is accomplished. As you can see from table 1, comparing the capacity of irradiated and unirradiated ion exchange resins can be used to investigate the influence of dose rate or ion exchange capacity. Now, the theoretical results show that resins lose 7% of its original strong acid capacity when exposed to a dose of 6.1 times 10 to the power 7 or 10 to the power 5 grades. So we'll go to the next slide. The budget of this research was 1,208,592 rubles. And the comparative study was done in order to pick the best method that may not require a huge budget. The next slide shows the hazards involved in this research, of which our researchers may be aware and plan for emergencies in case of any danger. So we can look at the conclusion. We can go to the next slide. Okay, so the result, average absorbed dose to gamma radiation was 2.74 kilogray with activity of 1,181.1 gigabecquerel, and the capacity for irradiated and unirradiated ion exchange resins was found to be 1.42 equivalent grams and 1.45 equivalent grams respectively. So the recommendation that whoever would like to do this research in future should be able to combine the indirect method with cementation and compare the results. Thank you for your attention.
So, Davis, thank you very much for your talk. Do we have some questions to Davis? Questions, please, to Davis? Okay, it seems to me we don't have any questions to you, Davis. Thank you very much for your talk.
Thank
Davis
you for
was
paying
our
attention.
Okay, Davis was our last speaker for the second session. In this way, I want to close our session, and I would say thank you very much for every participant, for every speaker. Thank you very much for your attention, and see you. Have a nice time. Goodbye.
Thank you very much. Thank you very much.
Теперь надо идти в зал туда, где ученый совет. Там пленарное заседание окончательное, короче. Вот вообще. Сейчас, я думаю, волонтер вас проводит. Если хотите, ну, как бы, есть волонтер. Нет, это же не у меня. Но я попробую выключить. Я могу только... Спасибо вам большое. Да я сейчас вот позвоню, закончу. Я боюсь, как бы все не...
Нет, тогда не надо.
Нет, мы все. Наша секция все. Я сейчас позвоню Станиславу. Понятно. Нет, пожалуйста, я знаю, что у вас все как в аптеке. Что? Алло, Станислав,
Надежда, да?
Я могу закончить вебинар? Да, все, спасибо. Спасибо большое.
Все отлично. Спасибо вам большое, огромное за помощь. Спасибо огромное. Прям вот нечеловеческое спасибо.
Да.
За терпение, вот за все это, что сегодня мы с вами сделали. До свидания.
До свидания.
Хорошего.
Спасибо большое.
Вам спасибо огромное. Рада была знакомству. И Свен тоже вам говорит спасибо большое.
Сейчас, секунду. Спасибо вам большое за помощь, за все. Была очень рада виртуально познакомиться.
Да.
Всего доброго. До свидания.
Всего хорошего. До свидания.